Call the meeting of the Maryland Healthcare Commission to order. Agenda item number 1 is approval of the minutes. I will entertain a motion to approve the minutes of the June 20, 2019 public meeting of the Commission.
Second.
A motion and a second. All in favor?
Aye.
All opposed? Hearing none. At this point, I probably should have done that before, but is there anybody on the phone? Any commissioners on the phone? No. All are present. Very good. Moving on to agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Seeing none, does the executive director or the center director? Was there a question?
I just have, on page 11, when talking about the healthcare quality reports, we're being given numbers, but is there any expectation of where we want to be in terms of how many people are using this? I can't really evaluate whether the numbers are very robust or not.
You're talking about the Poliquin website, the number of hits or visits,
Mm-hmm.
right? We do want to increase those. We've done some promotional activities. We haven't set a target specifically, and we could do that at some point, but we definitely want to increase the visits to the website.
They didn't seem terribly robust to me.
They're not. They're really not. We've been trying different strategies, and we have other strategies for promoting it as well that we plan to pursue over the next several months.
Well, it's amazing information, and it seems to be in terms of people's perception.
And we also plan to redesign the website. That's on our to-do list, if you will, for this upcoming year. So we're hoping as we do that, we'll also expand some of the promotional activities as well.
Thank you.
Does the executive director or any of the center directors have any additional updates?
So I have a limited number of comments today. Basically, they'll focus on our legislative responsibilities that were assigned to us in the 2018 session of the legislature or the 2019 session. Today, you will hear from the staff on the recommendations pertaining to electronic prescription records. That is an assessment. That was legislation adopted in 2018 that required us to do a study on the feasibility of incorporating non-CDS records in a service that would provide that information to physicians and other healthcare practitioners to guide them in care delivery. The infant mortality workforce, it's a work group that's been in process for a year and a half. Again, an outgrowth of 2018 legislation. We will meet tomorrow. That would be the 4th meeting we've had. We plan to have 2 more. The work group is considering some preliminary recommendations. We will get that final report to you later in the fall. The school-based telehealth work group, that was really a work that was born out of feedback from the then chairman of the Senate Finance Committee, is considering a draft recommendations. The work group has been very participatory and appropriate, given it includes both the Department of Health and the Department of Education. At this point, we expect to have a report to the Senate Finance Committee in November after review by the Commission at the November meeting. Our 2019 work that was triggered by actions in this last session of the legislature. We are working with MIMS in developing a actuarial assessment of mandating certain additional types of transport, EMS transport, specifically the use of payment for EMS visits where the patient is not transported. Typically that operates under a treat and release nomenclature. We're also looking at mandating alternative destinations where instead of a hospital, EMS would potentially transport a patient to a urgent care or drug treatment facility. And then lastly, also the broad framework for mandating private payers to participate in mobile integrated health programs. That's a pretty ambitious set of mandates. The Commission historically has been reluctant to add additional mandates. There's certainly at the same time interest among EMS organizations to get more directly involved in supporting the total cost of care. So we look forward to those estimates. We also
Can I just ask a question? Who's doing those estimates for you?
we have several bidders, several actuarial firms that have bid. We have not.
You're going to have actuaries do it, not health accountants.
We're going to have actuaries do it. The last meeting, we announced that we, working with HSCRC, had released what was called a task order RFP under their master's agreement to seek assistance in conducting the assessment of changes in the care services that were delivered at Chestertown Hospital, as well as the development of an set of options for continuing inpatient services at that hospital. We did not get any responses through that RFP process. The explanations were that the time frame offers thought was too tight. What we've decided to do is reconsider other options, including potentially a sole source for the options paper, which would be directed towards a rural health research center that's been active here in Maryland, and then a smaller procurement for a separate entity that would do the assessment of changes in services at Chestertown. Breaking it up into two would slightly increase the amount of work staff would have, but it actually may produce a better outcome because we would be able to pick a vendor who was very capable of doing the assessment and would narrow the responsibilities of the options assessment to an organization that was familiar with these issues, not only in Maryland, but across the country. And lastly, I wanted to let commissioners and staff and members of the public know that there is a potential for a telephone call commission meeting in August. It will be held on August 15th. Time is not yet certain. The reason is that we have received a request from Baltimore City to obtain information from the medical care database for litigation against 30 some pharmaceutical manufacturers who the city alleges aggressively promoted opioid prescribing over the last decade. The medical care database, the APCD, contains prescribing information that the city and its external counsel believes would be useful in documenting those strategies. And they have emphasized, given that this is a legal matter, that they would want us to address this request promptly. They do have the option of obtaining a court order rather than pursuing along those lines. We believe that it would be better to encourage the city to go through our normal process for applying for the data, which culminates in commission approval. And therefore, we are trying to accommodate them. They have not submitted an application yet, so we would not schedule that meeting until we were sure that the application was complete and approvable by the commission before we brought this together. But I wanted to give notice that this could occur if it's not submitted to us by early August. We would simply defer it to the September meeting and hope that they did not seek an order to release the data to us.
You can see what they want. I mean, we're going to make sure there's a discovery deadline that requires an extra meeting, right?
Yes.
Okay. Because I mean it would seem odd that we would be up against that type of discovery deadline on that short notice. So this couldn't wait until September.
I don't think we have a discovery schedule yet, and I'm not sure if we would even have that. But
I think it's fair to ask them for the discovery deadlines prior to scheduling an extra meeting.
Sarah, do you have any?
There is a little discovery schedule set.
All right. So it seems. I mean, we'll look at it as it comes up, but it just doesn't seem like it's an August deadline here.
That's all I have.
Before we consider additional items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should move to the MHCC conference room. Staff will let you know as soon as the commission has completed action on an agenda item, and then they'll move back. Kevin McDonald has a new employee to introduce.
Yes, I'd like to introduce Laura Lawson, who joined the MHCC a couple of weeks ago, coming over from the Maryland Department of Health, where she served most recently as a senior health policy advisor to the Maryland Community Health Resources Commission. Prior to that, she was the health equity director in the Office of Minority Health and Health Disparities. She earned a PhD in biomedical sciences from the Albert Einstein College of Medicine and an MPH from Southern Connecticut University. Prior to beginning her career in public health, she was an associate professor at the University of Copenhagen. And as an additional point, I learned a couple of days after she joined us, she joined her kids in jumping out of an airplane. So we're going to be giving her the most challenging assignment.
Welcome. Very glad you landed safely here.
You heal well.
On to agenda item number 3. Certificate of Need, Maryland Surgery Center for Women, LLC, establishment of an ambulatory surgical facility. There are 2 CON applications on this month's agenda in which the Physician Office Surgery Centers, or POSCs, propose to establish an ambulatory surgical facility by adding a second operating room by renovating existing space. They require CON under current law, but as of October 1, 2019, the threshold for being defined as an ASC, or ambulatory surgical facility, and thus requiring a CON, increases to 3 operating rooms under legislation passed in the 2019 session. Under that legislation, a project of this nature, i.e. 2 ORs or fewer, will only require a determination of coverage, not a formal CON. These reviews were already in progress. These particular reviews were already in progress during the legislative session, and acting on them this month will give the applicants an ability to move forward more quickly than waiting until the legislation takes effect in October. If there are questions commissioners have about that process, please feel free to direct them to staff afterwards or during this presentation. But the first application is from the Maryland Surgery Center, and the staff recommendation will be presented by Program Manager and CON Analyst Laura Hare. Laura.
Good afternoon, Chairman Pollock and Commissioners. Maryland Surgery Center is a physician outpatient surgery center, or POSC, with 1 operating room and 5 procedure rooms in Rockville, Maryland. 60% of its ownership is held by AmSurg Holding, Inc., which is a part owner of over 260 outpatient surgery centers in 35 states and the District of Columbia. The remaining interests are held by 27 physicians, each of whom owns less than 5% interest. Maryland Surgery Center seeks to establish an ambulatory surgical facility by converting one of its existing non-sterile procedure rooms to a second sterile operating room. At the end of this project, the facility will have 2 ORs and 4 procedure rooms. The applicant submitted the CON because it has experienced significant difficulty accommodating additional surgical volume and has outgrown its single OR due to changes in technology and the transition of some higher acuity cases from hospital ORs to outpatient centers. With these higher acuity cases comes lengthier OR times and extended recovery times, which has pushed cases into evening hours and requires the facility to be open on weekends. Optimal capacity for an OR at an ambulatory surgical facility assumes it will be in use for a minimum of 8 hours a day, 255 days a year, and is calculated as 80% of those hours, which is equivalent to 1,632 hours per year. Maryland Surgery Center reached optimal capacity for its single OR starting in 2015 and projects demand for its OR to grow to volumes equivalent to 1.6 ORs in 2019 and to 2 ORs by 2021. Maryland Surgery Center projects this continued growth based on its transition from a single to multi-specialty center, its historic utilization trends, and a payer-driven migration of certain higher acuity level operations from hospital OR settings to ambulatory surgical centers. The project is viable and financially feasible because the applicant currently has the cash to fund the entire project, and the estimated cost of this project is approximately $183,000. The applicant expects that the existing staff will be able to support most of the volume increases associated with this project and are only projecting to hire 2.5 full-time employees. It is also expected that the facility will continue to be profitable during and after the completion of this project. The project will not have a significant negative impact on other providers of outpatient surgical services because case shifts from existing facilities will be a result of the previously mentioned payer-driven migration of certain higher acuity level cases from ORs, hospital ORs, to ambulatory surgical centers. It is expected that the project will have a positive impact on patient access and reduce the cost of outpatient surgery for most patients and payer types. Staff recommends that the Commission approve Maryland Surgery Center's application for a certificate of need, authorizing the establishment of an ambulatory surgical facility because the project complies with the General Surgical Services Chapter, has been found to be needed, is cost effective, is viable, will provide a benefit to residents in its service area, and will not have an adverse impact on costs and charges for these surgical services. The CON has one condition that is standard and required by the state health plan for all ambulatory surgical facility CONs, and that it essentially states that the applicant shall provide information to the public regarding charges for the full range of surgical services provided. Today we have 2 representatives from Maryland Surgery Center in attendance, and I'd like to introduce them. Brooke Rush, Administrator for Maryland Surgery Center, and Carolyn Jacobs, Legal Counsel. I'd be happy to answer your questions at this time.
Seeing no questions, do I have a motion to approve a certificate of need application filed by Maryland Surgery Center?
So moved.
Second. Second. All in favor?
Aye.
Aye. Opposed? Congratulations. You have your CON.
Thank you very much.
Agenda item number 4, certificate of need, Johns Hopkins Surgery Center series, establishment of an ambulatory surgical facility. The second application is from Johns Hopkins Surgery Center's series. They propose to establish an ambulatory surgery facility in White Marsh in Baltimore County by renovating an existing 1 operating room physician outpatient surgery center, or POSC, to add a 2nd operating room. Eric Baker, program manager and CON analyst, will present the staff recommendation. Eric?
Good afternoon, Chairman and Commissioners. The applicant in this review is Johns Hopkins Surgery Center Series, which is an entity that is owned by Johns Hopkins University and the Johns Hopkins Health System Corporation, each with a 50% share. The proposed project is to establish an ambulatory surgery facility, or ASF, to be known as White Marsh Surgery Center, or White Marsh. White Marsh exists as a multi-specialty physician outpatient surgery center, or POSC, and opened in 2007 with 1 OR and 2 procedure rooms. White Marsh proposes to add a 2nd OR.
The applicant projected a need for 2.2 ORs at ASF based on its existing system volumes shifting to White Marsh Surgery Center. This need is based on the applicable need definition in the state health plan. White Marsh projected its volume based on an assumption that all surgeons currently practicing at the facility will continue to do so, and that their case volumes will remain level. All new cases in the projections are the result of surgeons transferring existing outpatient cases from Johns Hopkins affiliated hospitals to White Marsh. The projections do not assume any increase based on market growth or shifts from other ASCs. The applicant states that the project is viable because existing case volumes of medical staff within the Johns Hopkins system is sufficient to fill the new OR, and the applicant has the cash required for the project, which is valued at $1.05 million. White Marsh states the additional OR will not have an impact on current providers in the service area, as all volume to fill the OR will be a transfer of existing cases from the Johns Hopkins health system. The applicant states this shift of patients from a rate-regulated hospital setting to a lower-cost setting such as the proposed freestanding ASF will have a positive impact on financial access to surgical services in the service area. Regarding the charity care policy and values reported by White Marsh, staff notes that the amount that White Marsh reported in its application did not differentiate clearly between true charity care and free care that would be more appropriately defined as bad debt, making a pure judgment regarding its charity care track record difficult. While staff recommends the commission find that White Marsh has met the charity care standard, staff includes in the recommendation that the commission attach a condition which has been crafted to enhance White Marsh's provision of charity care, as well as ensure that its future reporting correctly distinguishes between charity care and bad debt. In summary, staff recommends that the commission approve Johns Hopkins Surgery Center Series application for a certificate of need authorizing the establishment of an ambulatory surgical facility, as the project complies with the applicable standards in the General Surgical Services chapter, is needed, is cost-effective, is viable, will provide a benefit to residents in its service area, and will not have an adverse impact on costs, charges, or other providers for similar surgical services. Staff's recommendation to the commission includes the following two recommendations. First is required in all applications for ASF is that the applicant shall provide to the public upon inquiry information concerning charges for the full range of surgical services provided. And the second condition specific to this application is that prior to first use approval, White Marsh Surgery Center shall provide an enhanced plan to identify and service patients in need of charity care acceptable to commission staff that will ensure that it provides an amount of charity care that is equivalent to or greater than the average amount of charity care provided by ASFs in the most recent year reported, measured as a percentage of total operating expenses, and that it report charity care and bad debt as defined in the freestanding ambulatory surgery facility survey. At this time, I'd like to introduce Johns Hopkins representatives in attendance. Aaron Langley, Senior Director of Health Planning and Community Engagement, Spencer Woldonger, Director of Health Planning, Phil Lang from the White Marsh Surgery Center Administration, and Allie Abernathy, Senior Counsel for Johns Hopkins Medicine. At this time, I'll be happy to answer any questions.
Commissioners, questions?
Just one quick one.
Yeah.
This bad debt situation, is this that basically all bad debt was listed as charity care?
No, it was that it was ambiguous in the policy, so we just need them to correct their policy and ensure that bad debt is reported as bad debt and charity care is charity care.
Okay, thanks.
If we were to deny the certificate of need today, they could turn around and open their facility without one, right?
Yeah. No, they'd have to wait till October to do that.
Okay, so they could wait till October.
They would still require a certificate of determination of coverage.
Right. Okay. What's the charity care standard that would apply in that case? That's my question. Are we imposing a charity care obligation that otherwise would not be imposed because we started down the certificate of need path?
So I would ask Paul to come up here. We have talked internally about this, about whether how charity care provisions would apply, but have not reached any determination on that. But I think it's a viable question, given the key element of approval of a CON is conformance with the charity care policy.
We have a charity care standard for regulated ambulatory surgical facilities. And we are in a situation where the definition of what is a regulated ambulatory surgical facility is changing. So not only these facilities, but other facilities that we've approved to establish themselves as ambulatory surgery facilities have that. They've been required as part of their approval to make a commitment to provide a certain level of charity care. But as of October 1, many of those will not be ambulatory surgical facilities under the new definition that will be in the law at that time.
But in fairness to a program like Hopkins, I guess I can say this because I don't work at Hopkins, but if they have a charity care population, it's their choice as to whether or not to deliver that charity care at the main hospital, at one of its regulated facilities or one of its unregulated facilities. And they're likely going to be inclined, just as they would with any of their population, to take care of that population, that patient at the lowest cost facility available. And there's no evidence that they are somehow not fulfilling their responsibility overall as a health system with regard to charity care. So to me, it's sort of,
I think that's correct.
Commissioner.
Mr. Chairman, just an observation. I'm totally in sync with approving this, but I'm struck when we look at the cost of healthcare and we compare one OR to another as to the significant difference it costs to bring online or to do things. There's nothing we can do about it. It's just what it is. But,
You mean the $1 million for this one versus 100,000 for the last one?
100,000 versus $1 million. I mean, I
caught that too.
my friends at Hopkins, it has nothing, but it's just the real world, and I'm totally for this. It's just a new observer of cost of healthcare.
Yeah, that didn't escape me either. And we've got the for-profit entity figuring out how to do it for 150,000, and the not-for-profit entity figuring out how to do it for over $1 million. And you wonder where the balance is. But I guess my gut is that micro-regulating that at this level, it's their money.
Oh, absolutely.
So Hopkins has agreed to the conditions. I was asking my question because I was troubled by imposing conditions on folks who've gone down one path that could go down the other path without conditions. They've agreed to the conditions the staff is proposing.
It's our goal to serve the population, like you said. We have a robust charity care policy and practice, and we're going to continue it to become better, so we don't have a problem with the condition.
All right. Do I have a motion to approve a certificate of need application filed by Johns Hopkins Surgery Center series? Commissioner Gordon, second. Commissioner McCarthy. All in favor?
Aye.
Any opposed? You have your certificate of need. Congratulations. All righty. On now to agenda item number 5, CRISP's HIE designation agreement, Health Information Exchange. Legislation passed in 2009 requires the Healthcare Commission to designate a state health information exchange. For the first designation, MHCC established a competitive proposal process that led to the designation of CRISP for 3 years. In subsequent redesignations, MHCC has not sought competitive bids, but we have used the renewal as an opportunity to align the CRISP state designation agreement with the evolution of health information exchange in Maryland. David Sharp, Director, Center for Health Information Technology and Innovative Care Delivery, and Nikki Majewski, Division Chief, Health Information Technology, will provide an overview of key elements of the state designated health information exchange state designation agreement. Joining them at the table is Brandon Neuswender. Did I say that right?
Nice wonder, sir.
Neuswender, Vice President and Chief Operating Officer, and Craig Beam. Bem. Sorry. 2 in a row.
But you got Majewski. We'll answer anything.
Maryland Program Director for CRISP. Ladies and gentlemen.
Great, thank you. Good afternoon, Commissioners. Our presentation today will highlight key components of the new CRISP State Designation Agreement. We have some folks from the table, at the table from CRISP, and I will start off with just providing some background information around why we do this process and the purpose, and then we'll go into the key components. So the state law back in 2009 required us to designate a statewide health information exchange. CRISP was competitively selected to build and maintain the technical infrastructure that supports electronic exchange in the state. The designation process consists of MHCC developing and executing an agreement, and then HSCRC votes on MHCC's action. The agreement that was included in your meeting materials sets conditions for CRISP as the state designated HIE and supports efforts to advance a strong, flexible health IT system in the state. This agreement has evolved over the last 10 years, from a focus on building and maintaining the technical infrastructure to policy management that supports evolving the utility of CRISP. This will be the 4th state designation agreement executed. Listed here on the slide are the previous dates of the prior agreements. And I'll pass it over to David to see if he has anything to add.
Sure. So I think, thank you, Nikki. I think if you look to the monitors or in front of you, you'll see a pretty interesting diagram of with the state designated HIE in the middle and all the connections they have underway. To give you a glimpse of progress, we included in the appendix section a lot of detail. But if you think about it in terms of volume, CRISP in a quarter has moved more than approximately 9.6 million notifications. That's pretty impressive from where we started out back in 2004 with a concept of enabling health information exchange in the state. And there are so many more impressive statistics that are flowing through this sort of diagram. This is a representation of Maryland. When you think about it, this number of searches that have happened on the CRISP system in a given week, 87,000 searches. When we look at information delivered into the solution of any of the electronic health records that sit on their fringes, 440,000. If we're looking at prescription drug monitoring program, 228,000. And then, as I mentioned, with encounter notifications, we're well over 500,000 in a week. So we've evolved quite a bit since the whole notion of enabling health information exchange. We've included, again, lots of statistics, but I would also share with you the number of things that have happened in the past that have taken us to this point. In 2004, there was the whole executive order notion by the then President Bush, which wanted the movement of electronic health records. In 2005, this commission developed guiding principles for what it should look like. And also in 2005, there was the task force that the legislature asked this commission to take on, which was to study electronic health records and make recommendations around how those health records could be deployed and actually offsetting the cost through a later act that the legislature, can't talk this afternoon, passed that required private payers to do state incentives. And then, of course, the designation by this commission and subsequently supported by the HSCRC. And there were some planning efforts that led us to this point. CRISP wasn't just born. There was a planning grant back in 2007 brought together along with this commission and the commission next door, which funded some planning grants. And we used the national organizations, multiple organizations, to help comb through those results of the planning grants to ultimately end up competitively. So I think CRISP, the folks to my left, as Nikki pointed out in this process. Anyway, I will quickly keep us moving and in the interest of time and questions you all might have. And I think at this stage, we want to ask our co-presenters to talk a little bit about the governance structure.
Yes, thank you very much for the opportunity. We will be very brief, but welcome questions, and we're happy to dig into details as much as you all would like. David was very generous in saying that CRISP is here. It really, I think this slide points to the fact there's much stakeholder involvement, engagement throughout the state that really helped CRISP evolve to where it evolved to and hope to evolve much further. And we made a lot of progress, and we're proud of it, but we also have a long way to go. So in terms of governance, we really appreciate the partnership with the Maryland Healthcare Commission. We certainly also work very closely with the Health Services Cost Review Commission. We have our own board of directors with 17 members. And I really like the blue box, which shows the committee structure, because that represents over 65 individuals from all segments of the industry, consumers, providers, government, that really vet the large decisions, that provide strategic direction, and really help staff understand what are the needs and where should CRISP be focused. So we'll move on to the next one, but if there are questions about governance, please we can address them at the end. We like to think about the core HIE services in 5 buckets. I'm going to focus on probably the 2 bullets on the left, but again, certainly we'll discuss any of the rest any further you all would like. When you think of an HIE and the way I think we all thought of HIE 10 years ago, we thought about the point of care. A patient presents to the emergency department, they've never been there before, you can go into a portal and look up that individual. And we have been doing that for about 10 years now with various evolutions along the way. Since probably the last designation, we have a couple really important new capabilities that I think are worth mentioning. The first, as David mentioned, the prescription drug monitoring program. That's really been something that we're very proud of to have partnered with the Behavioral Health Administration and the Department of Health on. We have, in terms of PDMPs across the country, I think been most successful at taking the critical data from the state-run vendor contract, placing it in the workflow of clinicians. It's very important as you have things like a statewide mandate to check something that it can be convenient and that it always works. So that's something we're very proud of. The other thing we're proud of in terms of the way the technology is advancing is that you aren't, many people still are, but less and less people are going into the CRISP portal and searching for a patient. Now using some standard technology, we're delivering data into the electronic health records in ways that allow clinicians to use the systems they've invested in the way they're meant to be used. And so I wouldn't be shocked, and it's maybe our goal even, in a couple of years, very few people go into CRISP to look for things. Instead, CRISP is taking data from appropriate sources and putting it directly where it belongs. So it's an interesting maybe perspective from an HIE, but it's one again, we're very proud of. The other key service that many people think of are encounter notifications. This is another unique one where, while we're proud of the 500,000 a week to go out, I wouldn't be shocked if that number decreases, because we'd rather send the right notifications at the right time to the right people than broadcast a bunch of noise. And so that's been an effort we've been focused on this year that we think will evolve. The next 3, again, I will not spend much time on. I will highlight the population health support. We partner with the HSCRC to take certain case mix and Medicare claims data to provide reports that enable the total cost of care model in a number of different ways that I think we'll hear about later. So it's a unique service line for CRISP in Maryland. And then we partner very closely for public health. We're a nonprofit. We believe very deeply that these tools can and should be reused for the public good. And for program administration, we're in a unique role as a collaborative organization between industry and regulators to hopefully build support and enable some really neat care redesign programs.
Okay, thank you.
And one more quick, again, this is one where there might be many questions later. I'm happy to answer them. This is a graph showing our revenue over the past 10 years. And the thing I will point out, maybe the 2 things I'll point out. One is there was obviously a very large spike as we had capital investment to build the infrastructure that was necessary for the state to embark on the transformation to the total cost of care model. That essentially was the technology that could do things like deliver data into EHR seamlessly at the rates that David was talking about. The other thing I want to point out is that we in no means intend to keep our revenues numbers that high, and we've been very cognizant of sustainability. So most of our operational funds come from user fee revenue or from the HSCRC hospital assessments, primarily so that they can view the reports for rates, reimbursement, and total cost of care. Thank you.
Yeah.
Oh,
One
Question
question.
for Craig on this. Do the revenue totals here reflect the scope of operations in DC and Virginia, or is this Maryland exclusive? I think it-
This is the full regions. This is DC and West Virginia. Maryland makes it the lion's share.
okay, so now I will just open up for more review and discussion of the key components. I'll highlight some of the conditions moving on to this slide here with MHCC oversight. This includes a change in the process for procuring CRISP services. This was traditionally done through Memorandum of Understandings, MOUs, and we will be in consultation with the Maryland Department of Health and other state agencies to identify a new method for replacing the existing MU process, which will remain in effect until a new agreement is determined. This also highlights in this section of the state designation agreement insurance requirements. As for CRISP governments, it narrows the time frame for providing notice to MHCC of an anticipated merger, sale, lease, or transfer of CRISP assets. Regarding privacy and security, this includes the transition of the annual audits to CRISP, where CRISP is responsible for engaging an independent auditor to review and test internal and external controls. This includes the SOC 2 Type 2 review and notice of a time frame that reasonably prioritizes corrective actions to address any audit findings, and also a 24-hour notice of a security incident to MHCC. I am not necessarily going through all of them. These are some of the highlights, and so I know most of you have read the state designation agreement in your meeting materials, but please chime in if you have a question. As for collaboration with MHCC and CRISP, this includes a recognition of national policies that impact HIE efforts in Maryland and alignment as appropriate, mutual participation in MHCC work groups and the CRISP advisory boards that Craig mentioned, and consideration of some pilots for specific use cases. It also includes mutual notification when taking a position or commenting on HIE legislative matters between CRISP and MHCC. And also it adds some indemnification provisions and an annual review of ethical standards and best practices and requirements for CRISP senior management and its board of directors.
And what Nikki is pointing out is the changes in this version versus the prior version, just to reiterate that.
Do you want to hold our questions till the end, or
we yield to the commission?
Go ahead. Let's ask Mr. Gill.
Yeah, I just had a question about the, it's back on the slide, sorry about that. It's on the idea of engaging an independent firm at least annually to review and test internal and external controls. And I guess it's just a question of what is industry standard here. Certainly the idea of the organization picking their own auditor is common in financial. And part of that is I don't think IRS wants to get into that. But here where we're talking about security concerns, other things beyond simply, balance, accounts receivable and whatnot. Is it common that an audit like this, you get to pick your own auditor? Or is it, I mean, to a certain degree, it's, I come from an evaluation background, and you sort of never have the same people who are part of the, who are part of the program be the evaluators. You go totally separate, totally third party. Nobody has any kind of, I'm just, and no aspersions. I'm just wondering, is this how it's done in this very new industry where all of a sudden you're questioning questions of security, et cetera, or is there any sort of way that some more neutral third party picks who your auditor would be?
So, Commissioner Gray, allow me to make a couple of remarks and invite Brandon to fill in the gaps. Up until this last year, the MHCC was responsible for selecting and controlling the privacy and security audit. We use an industry standard auditing format, meaning the SOC 2 approach, which is very common organizations. We have moved in the direction for CRISP to make that selection, but it's made more broadly than just an individual at CRISP. They have an evaluation and review process. And why don't, Brandon, you talk a little bit about that as well?
Yeah. I think from an industry perspective, most firms do choose their own security audit engagement partner. They all set their own standards for the scope of work and what they're going to look at from a network and privacy perspective. In this case, I still believe there's a lot of collaboration with the MHCC as we set the scope together. CRISP is really still reliant on certain standards that are required, such as the COMAR and the HIPAA and the SOC 2, and beyond that, even from a security perspective, where we take guidance and almost from a requirements perspective to make sure we meet this standard. Individually, as an organization, we put out an RFP that met the specifications that were agreed upon mutually by the MHCC and CRISP leadership staff. And then we share all of those results back to the MHCC, which can make that available to the Commission and other stakeholders in the state. So I think it's not as independent. It's still a collaborative scope setting, and as we choose and ensure that the firms that we choose to do this are valid and can meet the standard of a good test, then that's how we
Yeah, my thought is more in terms of you're in an evolving new industry. And so, to use a financial services model or however, the way nonprofits have to file, et cetera, in an area where kind of whatever they call it, standard accounting practices are already very established, et cetera, you just leave yourself a little vulnerable here. That if it was some notion that it was clearly, you didn't, a neutral third party picked who your auditor was, would inoculate you a little bit from any question if, God forbid, there was a problem later on down the line. But if this is what's evolved, I certainly, not sure I would design it that way, but go for it, right? I think that.
So it's an interesting dilemma that you raise, Commissioner O'Grady, because previously the Healthcare Commission contracted with the external privacy and security contractor, and they conducted the audit. In the most recent reviews by the Office of Legislative Audits, that was one of the areas that the OLA had asked us that why we were doing that, pointing out it did not conform to industry best practices, that they contended that in these types of relationships, we should compel the vendor, if they will, using their terminology, to complete their own SOC 2 audits and then supply those reports to us, which we are now pivoting towards. I think there's probably arguments on both sides of this, but we also were interested in pivoting away from this because it was a OLA finding that we were somehow deficient by doing this. We thought we were actually being, especially vigilant. Yes. But their view was this is a job for the firm to do on its own and supply you with that information.
And I guess I would in general agree with that, but it's just, the IT stuff is so new. It's, I would just, if it were me doing the design, I would want that additional inoculation of a neutral third party picking. But I don't want to upset and slow up the conversation here.
And I might add, if Brandon could take just a couple of seconds and talk about the two types of industry certifications that speak a little bit to your concern about information security, that in the existing MOU was baked into it, if you will.
Yes, beyond a SOC 2 report, which is a standard report that evaluates our internal practices and security capabilities, we have obtained additional third-party certifications, one of which is a HITRUST certification, which is the recognized security certification in the industry, really kind of stemmed from the payer side of the industry, but it's now kind of been pervasive throughout even the provider side. Secondly, we also are ENAC certified for both HIE operations and cloud computing operations. So those are two very independent organizations that we do not engage with other than to make sure that they can evaluate us. And we have passed both of those and have progressed through the industry standards over the years. And quite frankly, we were I think we were the first. I know we were the first HIE in the country that actually obtained both of those security third-party certifications simultaneously.
Great. Thank you.
Okay.
Obviously, the privacy issues are critical to our oversight piece, but obviously the financial integrity of the organization is also critical to our oversight piece. You play a unique role in the state healthcare system, and if you were to have a financial challenge, that would be a big problem for us. So can you just speak briefly to the oversight of that piece of it? We review their audits and we sit on their board.
Sure, and it follows a similar sort of pathway that we've evolved to on privacy and security, where for many years this commission had ownership of the financial review. We selected a third-party accounting organization to go in and take a look at what was going on. And then only in recent years have we shifted that over to Chris. Again, the same level of collaboration on that, the auditor selection, same level of review. We participate on the financial committees, the executive board, the board level when they're discussed. We see the results. If there is a remediation identified on a particular aspect, we also monitor and work with Chris. I think it's fair to say on the financial side, the organization is well established. I think what we hear Chris talking about is moving more in the reliance of sustainability, where it's a user fee assessment and less more on, say, grants that are provided from the government. And what we probably glossed through very quickly was, and we saw on the first slide, the millions of dollars that we helped Chris receive from the Office of the National Coordinator back in 2009. Chris has received a sizable amount of federal funds and startup costs, and that was in part due to this commission, both securing it through the HSCRC for our collaboration, and we monitored how those funds were used and deployed, as well as through the state HIE cooperative agreement and the regional extension center. That was $9.3 million and another $10 million to boot. So there's been a lot of investment put into this, and there is, both from the Chris board standpoint and from this commission at the staff level, a lot of oversight and collaboration with third-party auditors.
Can I follow up on that a little bit? But it is very good that you try to move away from the kind of the grant, RWJ grants is not a good long-term strategy, I think, for any, research or anyone. So it is good, and to move seas. Now, in your chart, you do have just an other category. Would that still be those sort of Office of the National Coordinator grants? Is that what those are that are still, so your goal is to kind of wean yourself off those, or that they're kind of surplus, that's not really to the core mission? That's sort of icing on the cake if you can get it, but it doesn't keep the lights on?
Yeah, maybe to restate it in a very similar way briefly, we view our budget essentially as having a project category and operations category. Operations, we view sustainability as through user fees, through potentially HSCRC and other assessments if it's for operating things we've been asked of agencies.
Right.
And that's all why we're sustainable. The other category, do grant funding, do innovative projects. We would view as if they're feasible, if they're funded, and if they're demanded through our various stakeholder groups, then we would pursue those. Otherwise, there's no reason.
But that's sort of soft money. Okay.
Okay.
Great. So, and then the last key component I'll mention is that the state designation agreement may be amended based on agreement between us and Chris, and then we're expanding the duration of the agreement from 3 to 5 years. So,
Can I ask why?
So that's a very good question, Commissioner. In part because as we've stepped through, there aren't significant changes that we've made between the last 3-year agreement and this one. But the opportunity to shore it up and make changes exists all along. So this is more of a formal structure to amend and bring it to the commission. 3 years, it seemed reasonable, given that there hasn't been a lot of changes that we've come back to you all and requested approval to execute. It seemed reasonable that 5 years would be sufficient.
It seems to me, and this is not intended to be negative towards Chris at all, but normally if we're looking for a vendor, we're going to an RFP, we're seeing what's out there, and we're doing it on a regular cycle. And 3 is more customary than 5. In this case, we do have a relationship with Chris, but at what point are we going to want to go out and see who else is doing health information exchanges in the marketplace in a very dynamic, fast-changing environment?
That's a great question. I can start, and others that might want to weigh in. So you bring to light something that staff has already begun to do. We're developing a request for proposal to look for a contractor that can assess HIEs nationally, and we can do a comparison of benchmark to CRISP. CRISP has in the past done some of that work on their own. It brings us back to the independence that I think Commissioner Brady was bringing up if it's handled by the state. The other thing I would note is that when HIEs were established, they were more of these brick and mortar hubs. They were claims clearing houses. Essentially, if you think of the transactions that were to flow through them, over time, the networks that have evolved, and you heard Brandon and Craig mention a little bit, where information is being placed within these solutions. And the complexity of an HIE is no more along the lines of just simply moving transactions, but they're value-added networks. And what the work that CRISP has done in Maryland, as you've seen and you're hearing about, has a tremendous value to the larger network of the healthcare system. It would be amazingly disruptive to the healthcare system if, say, we decided we were going to just issue an RFP, and if CRISP won it competitively, we would unplug and plug somebody else in. That doesn't work well when you move from an environment of just simply moving transactions to where you have a distributed model that's providing analytical support and evaluation of the data that's moving between the partners. So what we've done in this agreement, we've said that as long as there's been a continuation of progression, and meaning that the quality is there, that the services are there, that they're needed, and they've done a reasonable good job, which they have, there wouldn't be a need to recompete. However, that could occur if things were to change, or in the event maybe CRISP were to be sold or chose to go out of business.
When you say if things were to change, other than a reduction in CRISP's services, what ability do we have to say, no, we go out in RFP, we need to rethink this because the outside world has changed? Say CRISP is doing fine. It's what we told them to do. Everything's hunky-dory, but the world around us has changed. What ability do we have under this to say, now we need to go out to an RFP to rethink this from scratch?
So the commission designates, so the commission has, in collaboration with the HCRC, has the authority to look at alternative options. From a staff perspective, we would absolutely support the will of the commission, but we would encourage a bit more due diligence to examine any concerns that the commission might have regarding performance, quality, and cost before we would suggest that format.
Wouldn't that only be at the 5-year mark?
No. Can that happen before the 5-year mark? Can it happen at the 2-year mark? For example, if the world changes entirely and there is a new widget out there that provides all this information a lot faster, and a lot more reliably, and CRISP isn't doing it, but company B is doing it in Nebraska. Do we have an ability after 2 years to say, hey, we want you to rethink this agreement?
I would yield, Mr. Chairman, to the attorneys for that, but I would say based on the agreement can be canceled in 90 days by either partners.
That's the answer. Okay. It's got a 90-day difference.
At the same time, I think Randy has a good point there. If you're going sole source, I mean, even if it's pro forma after 3 years, you kind of go, great job, kiss on both cheeks, keep up the good work. There's something that says if you're going kind of a sole source sort of an operation, that you probably don't want to do both move it back and go sole source. So, I mean, I would be, if I don't know, I'm putting words in your mouth right now, but if you were more comfortable sticking with a 3-year window, I would second that. Without kind of, I mean, to a certain degree, I hear what you're saying, David, about kind of, you know, the disruptive effect. At the same time, we don't want to kind of turn CRISP into pseudo state employees. You're your own organization and you have your own things that are going on there. So you want to institutionalize this to get the stability, but you don't want to institutionalize it to get sort of a little too one way of doing things and right.
So if it's the will of the commission, I don't think our
So,
partners would object.
Yeah, I might make just two very minor points. The first, yeah, we would not object. I thought David just didn't want to work with us that often, but we're very comfortable with the term distribution order. The other thing I'd point out, kind of the way that it might be easier for the internal people at CRISP to think about this is we're not a vendor offering kind of single solutions.
Right.
We believe in a best of breed model. The services we enter and exit, change relatively frequently. 3 years ago we were not in the PDMP business, and now we are. And so I think part of the kind of lengthening period of the agreement is to say this is a collaborative body with broad representation that kind of can and should evolve, but the stakeholders, the framework can remain in place.
Yeah, I don't think any of us is implying that that's not the case right now. I think we're implying that our fiduciary responsibility is that in the event that you two were suddenly struck by a bus and replaced by two people who are not as committed to the future of the product that CRISP is, we would have an ability as a state to look in a different direction. The 3-year forces us as a state to do that. The 90-day out allows us to at any point. So I guess that's the balance between forcing us and forced and allowed. Do we want to force ourselves in 3 years to look at this again?
We can make that help.
Yeah.
I have a quick question.
Yes.
How much does this cost? What is our cost?
Our cost is a staff commitment.
So there's no fees that we pay.
We don't, well, I want to qualify this that because CRISP is the state designated HIE, there is one service that they provide to MHCC through a grant arrangement, which is to add what is called the encrypted patient ID to our all claims payer database that we pay CRISP the cost of. CRISP holds, as a result of its work, something called a master patient index. We use a version of that re-encrypted and applied to our all payer claim database so that patients, as they change insurance carriers, can be consistently identified, not as individuals, but as users. So if Ben Steffen goes from Kaiser to CareFirst as through insurance, without this encrypted patient identifier, my utilization is lost when I jump from one insurance company to another. By using the EID, this individual total cost of care utilization for a year, for example, could be accumulated across multiple payers. We think it's a significant benefit and of particular interest to some of our academic researchers. I believe we pay you $100,000, $200,000 to do that work, which we think is competitive with what would other vendors would charge. I have no position on the 3-year agreement. I would want to emphasize, though, that because they are the designated HIE, that does not mean there are not other health information exchanges operating in the state. We're not locking others out, which can cut both ways. There are others that could theoretically do the work. No one has come, David and I do sort of test the waters when we go through these agreements to think, is it worth it to do a competitive, and we've always come up with that the other entities are comfortable in the roles that they have and are not necessarily interested in becoming a state designated HIE, which includes additional responsibilities. But I'm open to whatever I think the commission is at its own decision in terms of duration. CRISP does not object one way or another.
Obviously, the revenue, $27.8 million, is being paid by a lot of other people other than us. So, I mean, we're making this decision, but if we said no, we weren't going to do this, does it really matter? I mean, because HSCRC's got users fees, everybody else is using this system. So I'm just saying, we're
Well, they
approving
use it
something.
because they're the state designated HIE.
That's what I'm saying.
Kind. So the designation allows agencies and other groups to use us, but if we were not performing on those contracts, they would not use us. I mean, I do think there is a competitive environment in funding.
I mean, we're not the only
beyond
decision
HIE.
maker for each of your services outside.
No, but
For the
we're
regulatory
we're the
decision
regulatory
maker,
decision maker.
rather than
So
our economic.
if we did not designate them, many of those other contracts would likely go away. So this is not a pro forma action.
I would agree. And those other arrangements with other state agencies are predicated on the designation agreement. I agree with what Craig said, that if they weren't performing, they would look at those agencies would look at other options, but it becomes just easier for those other options, other entities to use the state designated HIE because they are the state designated. And David and I consider that very carefully. And as a result of those thoughts and input from others, we've more closely defined the endeavors in which CRISP can engage in this latest agreement that was more open-ended in the past.
Right, sure. Good point.
What percentage of patients are enrolled?
So across the population, I think the question you might ask is the opposite of that. How many consumers have opted out? And I believe the number I have here says no, it's not an opt-in. Maryland is opt-out.
Information on patients.
So
So CRISP is connected to all 47 acute care hospitals, about 200 skilled nursing facilities.
That's you connected to an EMR with like Epic.
That's right. And so they share
I'll
data
go
with
on.
us.
I'll go on CRISP and Epic. It says not available.
So that could be a number of issues. It could be a patient has opted out.
So you
which is the
get
right
an
thing.
automatic feed from EMRs and the state. Okay.
and they have nurse home
There's no other
connections and
information.
ambulatory plans.
There's no other information, Chris, we can get that about that patient.
That's right. But the question you asked about opt-out, I think if the last numbers for Maryland, we have about 8,400. So
Otherwise, the entire state is in the system.
if you are seen in a healthcare system here in
Right.
Maryland.
If you don't see a provider, you're out.
See it.
Right.
Right.
You know,
Yeah,
not
like claims did.
Not like Google, where they come looking for you.
Right,
regardless of
right.
what-
No, like claims data, where you never see the people who.
So if you present to a hospital inpatient care, you're automatically in a CRISP system
Unless you opt out.
unless you sign something up there.
Yes, we do work with all of our participants under COMAR regulation to provide patients with information at the point of care. Some patients read them, some patients don't. But we've really upped our game in trying to make sure our patients understand that in this new world of healthcare and technology, a lot of information moves around, and outside of CRISP and people don't know where their health information is going. So we've made our participants put information directly in the notice of privacy practice. We've enforced. We put opt-out information at every one of our participants. We allow them to call us, and the national opt-out rate in others is between 0.08% and maybe 1.5%, and we're right in that mix. But it is one of the things that as we continue to move forward, patient privacy and consent is at the forefront of what we're trying to do, pushing new solutions, pushing more ways for patients to engage with us that are easier than going to our website and putting in their information about saying, please don't share any of my information. But we do have multiple checks when someone opts out outside of PDMP data. All of that data is removed from our databases and is not shared through CRISP. So when you see a patient not available in CRISP, that could be one of the reasons.
And the prescription drug monitoring program, as Brandon mentioned, that's the only area where patients aren't able to opt out of because it's statutory requirement.
But how thorough is it? I mean, is it voluntary? Like a primary care guy doesn't have an EMR, that patient. So how does he get that information? He has to go into CRISP, upload it.
a lot of our information is dependent on how, sophisticated each one of the practices are. So if you've invested a lot of money in maybe an Epic or an Allscripts or another EHR vendor, and you can make those connections with CRISP automatically, they happen. And we've been very thorough moving through the state. We've got a bunch of different programs that have allowed us to engage provider practices and help them through that, and even offer some assistance. When a provider doesn't have that type of sophistication, we have ways where they can connect directly into systems that sit alongside their EHR so that they can see that information and get access to it, even if their technology investments aren't as sophisticated. So we offer multiple ways for providers to get at the data, but our aim is to make it as simple and easy to get at as possible so they can make decisions.
Send those to urgent care and prescription, an X-ray, whatever. Does that information become available?
Sometimes. It depends on, for the most part, if people have engaged with CRISP from an image sharing perspective, those images would be available, full high quality images. Different urgent care centers definitely send us information. We're working to get urgent care information as those communities come more technologically.
Commissioner.
Just a quick observation. Still learning terminology and how this whole thing works. I took the liberty of going on the website. Do you all spend any time looking at the website from the standpoint of the outside or to understand? Is there a place where I couldn't find who's on the commission, some basic things, and I admit I did it real quick, but all that kind of thing available. I mean, who's on the commission and all that.
I'll try and be very brief. We know that the patient-facing material historically has been very important. We just recently engaged a third-party group to redo all of it, and our For Patients tab has been modified with plain language and clear videos and much better information. It's a complicated system, and so I do think we need to do more work, again, from an outsider perspective to understand how data flows, what patient rights are.
Well, I think just the governance, who's on the commission. I mean, I saw that it's 2 days and 3 days and 2 days. I find that very interesting. Understand how it works. Besides you all run.
Yeah, and we list the board members. Yeah, we list the board, but not all the committees, which I think would be important.
All right. At this point, I believe I heard a motion with an amendment. Yeah.
Just one quick comment. So before you get to the motion about, I guess, 3 years or 5 years before term, right. I think the one observation that would concern me is the opposite end. It's not necessarily our ability to walk away in 90 days, but also CRISP's ability to walk away in 90 days. So what protections does the state have in terms of if we have such an intricate system of information sharing, right? There's nothing stopping these gentlemen from giving us 90-day term notice September 1, right? And then what would the state and the facilities do in terms of remedies or operations? So I would be thinking from a contractual standpoint, not so much worried about 3 and 5 years. I have my own thoughts on that, but some protections on both sides that would at least give us more run room to put together a reasonable RFP to seek a new vendor should the vendor choose to terminate with us is the main thing that struck me from a 90-day out clause.
They terminate with us, they terminate as the designated health information provider. It doesn't necessarily mean that they terminate with each of the other entities for whom they're providing services. So that's the challenge. We don't control that piece of it.
But there, to Commissioner McCarthy's point, there's areas on insurance requirements in the agreement, which are new this year, follow pretty much the state procurement laws. There's also a section on termination, on what they have to do to terminate with us. It gives us the ability, gives the commission an ability to decide how it wants to move that designation on to, say, another organization, and that information that CRISP controls to move it elsewhere. So there is that capability within the designation.
So it's worth asking the question of, I think the answer is no, but if Chris provides 90 days notice and it terminates, and we don't have a replacement designation, is there a service that is lost? Does somebody lose service because of the termination with us, or is there some other termination clause under some other contract that will control all of the service?
So I think that's a great question. The short answer is it's complicated. The long answer is the way the organization is structured and the way it's already baked into the workflows, they couldn't just simply flip a switch and walk away. They could cast aside the designation, and then their state has the MHCC as the overseer of the designation agreement, has some ability to do other things. It has time to look for another vendor. It has time to move the data, make requests of the HIE. But the HIE in of itself has commitments with the agencies it does business with. It also has contractual arrangements with its partners, hospitals, ambulatory providers. So a simple thinking of technology that used to be just where it was plug and play no longer exists.
And we sit on their board. So that if there is an organization like that doesn't go out of business overnight, it doesn't decide that it's not going to do business with its primary source of legitimacy, if you will, the state overnight. That if we're headed towards a process where that's a risk, then our representation on that board would be back to us to say, hey, we need to start looking at potentially bidding this thing, exercising our 90-day, walking away, or somewhere in between.
And to a large extent, the document reflects a successful 10-year partnership between industry, who sits on a board, and our regulators.
Once again, we're assuming all this means that the two of you were hit by a bus tomorrow.
There's many other people doing much more work than the two of us.
So, sorry. Yeah, right. So I think I heard that from Commissioner Grady before, but did I hear a motion that?
Happy to make one.
That we designate Chris as the state designated HIE with the amendment that the agreement be for 3 years.
So move.
Second. Do I have a second for an amended motion? Any additional discussion about that amendment? Hearing none. All in favor?
Aye.
Any opposed? Congratulations.
Thank you very much.
And I don't think we sit on their board.
The state representation, there's two, the secretary, but Ben and I
We're ex officio members of the board.
Are you voting members? No. So
it's the communication.
Okay.
Back to us.
We attend.
Okay.
Don't eat your food. Right. That would be a violation of state protocol.
Maybe water. But no.
All right, agenda item number 6, action on the non-CDS work group report. So House Bill 115, MHCC Electronic Prescription Record System Assessment and Report was passed during the 2018 legislative session. That law required the MHCC to convene interested stakeholders for the purposes of conducting a study to assess the benefits and feasibility of developing an electronic repository of non-controlled dangerous substances. Nikki Majewski, Division Chief, Health Information Technology, will provide a summary of the suggested recommendations included in the report. Majewski, the floor is yours again.
Thanks. Good afternoon again. My presentation today will highlight recommendations proposed by the Electronic Prescription Records System Work Group, which is intended to provide a practical foundation for developing legislation that mandates reporting of non-controlled dangerous substances dispensed in the state. The concept of a non-CDS statewide repository sparked a lot of interest by stakeholders during the 2018 legislative session. And it's important to note that the original version of the bill would have required MHCC to adopt regulations requiring pharmacies to report non-CDS information. And this would also be leveraging the existing infrastructure through the PDMP, the Prescription Drug Monitoring Program we just mentioned, supported by CRISP. The notion of moving the bill forward generated support for the concept, but also some opposition among stakeholders who were concerned around consumer privacy and the view that the bill was anti-competitive. This resulted in the bill being modified to require this study. So in general, just sort of help frame the presentation, support for this repository is given its great potential to provide clinical value by improving the medication reconciliation process, to improve patient safety. And the value proposition is particularly high in an emergency department setting when decisions need to be made quickly and sometimes clinical information is lacking. And in Maryland and the nation, at least half of all admissions come from the ED setting. Medication discrepancies too, literature finds that result in inappropriate or interrupted drug therapy after hospitalization are the result of almost half of preventable readmissions within 30 days after discharge. So House Bill 115 tasked us to assess the feasibility of developing a system and then report on our findings and recommendations to the Governor General Assembly in January of 2020. So just a little overview around the approach. We did convene interested stakeholders, about 81 members served on the work group. All meetings were open to the public and working papers posted on MHCC's website. Meetings were facilitating using a roundtable discussion approach where stakeholders shared perspectives on a wide range of policy and technology matters. And existing mandates and infrastructure for the PDMP in Maryland and others in the nation informed the work group discussions. Key themes that emerged were used to formulate draft recommendations with a small subgroup. That subgroup was open to all on the work group and the public. And then we brought those recommendations back to the full work group, and they were developed iteratively through working papers to develop the final draft that you see in the report today. So moving on to the key recommendations. The first relates to, they're categorized under 3 categories. The first here being implementation. And the first one say requiring the work group recommending that a competitive process exists for one or more vendors to be recognized to participate in the repository. And this recognition process would ensure that certain technical standards and privacy and security controls are in place. Some work group members support the concept of a multi-vendor approach that integrates with CRISP. The second recommendation builds on this by leveraging the existing solutions that are available today. And the thought here is to support competition to allow non-CDS information in addition to the controlled dangerous substances that's made available to date through the PDMP to get into existing workflows.
Can I ask one question? When we talk about a multi-vendor approach in this context, does that just mean multiple vendors with their own repositories? Or is it broken up in some ways to some vendors in different parts?
So there would still sort of be the vendor that CRISP contracts now to provide certain specific IT functions that could potentially feed other vendors like CRISP or others who would want to participate in the data so that they could have the full record, including non-controlled and then the controlled dangerous substances.
Okay, but there's still sort of one party controlling a repository of that's not multiple repositories.
So
But they're just trying to get a mental picture. I'm not saying one better than the other.
I think Nikki's answer is good, but let me just sort of build upon your question. There's the endpoint integration, which with the gentleman from Chris spoke a great deal about how that integration sets up today. Between a pharmacy information management system and between that endpoint integration, there are a lot of vendors along the way because it's an aggregated system where it's component based. And what we heard from the stakeholders is that We don't want there to be necessarily a sole designation in this link, in this chain link. We'd rather have competition. So vendor A can compete, vendor B, and you could have vendor C, and you could have a distributed infrastructure where the information still flows from the pharmacy information management system to Chris, as opposed to just designating someone to do from A to Z.
But we already have somebody for the CDS stuff. That's already sort of
The CDS
established.
has been established for several years, correct?
But we have whatever we have, 5 or 6 major PBMs out there that are all in competition and cover some percentage of the state population.
Yeah.
Whether it's Medicare or Care First or whoever.
Yeah, and that's fair enough, but it's really agnostic to the PBMs. So you could have a multitude because the endpoints, the viewers of the system are the healthcare providers, the physicians. If you're a prescriber, if you're a dispenser, a pharmacist would be looking at it. It could be a physician, someone in the hospital as well.
I'm only thinking of them as they're the people who have the data. And then you're talking about these intermediaries to get it to the end.
Well, so to expand a bit more, a lot of times when you think about a controlled dangerous substance, it's not a third-party payer. It's not necessarily a third-party payer. This could be someone who's a drug seeker, someone who may have acquired a prescription illegally. And what the attempt of the PDMB is to say anytime somebody presents in an emergency department, have they been taking a controlled dangerous substance, as opposed to who's the payer in this process.
But in the non-CDS.
In non-CDS, it's not to this extent. Its use is different. It's from a medication history standpoint.
Right.
That's why today, under the PDM, it's a dispenser, which could be a physician. Whereas in this model that's being discussed, the dispenser is the community pharmacy.
Got it. So we know it's filled, not just what's written.
Correct.
So, I'm sorry.
Did this study you speak about, did it compare compliance of the patient with the repository versus without a repository and see if the outcome was still different? Or does it matter? Why do you even have a repository if the patient's not compliant and it's not going to change outcomes? Why have the expense of this?
Well, so we didn't dig too deep into that, but the concept of patient omissions that don't, disclose certain information, or they forget, or they're incapacitated, did come up. So the focus was on the value of having this information to fill in gaps and make informed clinical decisions by having this full medication history.
And there was much discussion about trust first and verify, trust but verify, because the clinicians in the room said, how can we ever be sure that the patient's taking what's dispensed? But then some of the emergency room physicians were saying in the room that my patients arrive unconscious, so I don't get to ask them or to verify. But having some medication history that is better than what we have today.
You want to know if they're diabetic, whether they can tell you or not.
Yeah. Now, technology is evolving where eventually pills will have this little tiny
No, we know everything already before they.
I gotcha.
Okay, so lastly, although third recommendation would be to convene an advisory committee to guide policy development, including any potential exclusions or waivers. So moving on to consumer privacy, there are 3 recommendations listed here, and they stem from the concerns expressed around consumers' ability to control the flow of their non-CDS information, particularly those with sensitive and stigmatized illnesses, or those seeking services, including minors, for behavioral health or reproductive health. So the work group recommends implementing a consumer non-CDS opt-out process. And that would be supported by education at the point of care to inform consumers about the benefits of sharing their information and potential disadvantages of opting out. And then the last recommendation is to ensure these protections are codified in statute. So the last category around governance and funding, the first recommendation aims to ensure that any non-CDS reporting regulations are informed by existing state regulations. The work group couldn't exactly conclude on a funding source, but the general preference was a public funding approach. The next slide talks a little bit about estimated cost and a potential funding option. So, cost first. The development and implementation is estimated to be approximately $750,000 with annual maintenance and support around $500,000. There was some thought around doing an assessment of hospitals to support.
Let me guess, there was no hospital representation on the group.
No, we had hospital representation.
Yeah, they did it quickly.
Well, I think as you'll see when Nikki talks about the cost, when you think of $16,000, that's how far back to the right of the decimal point on the hospital operating budget of the hospital. I guess I'd look to Commissioner Reimer for that.
Well, it's the bottom line of the hospital that are running less than 3% margin, which is not sufficient to meet the capital needs of the institution. So
fair enough.
Okay, so sort of the rationale for potentially considering this approach is listed here. I'll move on to the next slide, which is sort of just some key points that you can.
Can I just ask one? Where did you come up with 750,000 from?
So
it seemed low.
Sure. Well, it's always easy to increase the number, but the reality of it is we looked at the cost to develop and implement the PDMP. We said because this system parallels it. In fact, the cost to this system will be a little less than PDMP because of all the different endpoints. So the infrastructure is built. So we use that model to come up.
But you guys came up,
yes.
Staff came up with
That's correct.
not this group.
That's correct.
Got it. Good. Good. Sorry for the interruption.
No worries. So this sort of forms the basis around how we arrived at these recommendations. And I'll pause here for you to review or ask any more questions before you take action on approving the report.
And how many hospitals are there in the state of Maryland?
47 acute care hospitals.
And if you were to give me an estimate on how many including the urgent care centers and smaller medical facilities of that nature, not a doctor's office, but those kinds of centers where somebody would just walk in, it's not a hospital, how many would that be?
Yeah, that is a great question. We'd have to get back to you on that. I'm not sure I would be able to answer that off the top of my head.
Because that would be a more likely user of the system, right?
Well, there's mixed views on that. It would be both ambulatory providers. It would be urgent care centers. It could be a nursing home for transitional care for seniors. It could conceivably be a lot of different areas within a hospital. So we can think of a multitude of users of it, but the assessment model that we looked at focused on just the acute care hospitals in the state.
This is just a report that goes to the General Assembly and allows them to consider in the development of legislation going forward. So we're not establishing a payment option for 500,000 or 750,000 or any number.
But we're putting an idea on the table, as this is one of the feasible ones. And so kind of the non-decision to add other options, having been one of those legislative staff that receives such reports.
Most of the patients that present to the hospital now have a list of medications. We see the medications reconciliation to the point where you get sick and tired of seeing it. I don't know benefit. I don't see the benefit. We have this money for this. People come in unconscious, you gotta treat them. Give them glucose, give them Narcan, whatever, treat the acute emergency. And then figure out later on, diabetic or narcotics. Anyway, so I don't, medication errors. I see patients like come in with a grocery list of medications. It gets on the chart. I don't know where the medication error is.
So sometimes they say they're on a drug, but then they're like, it's the dosage frequency. And Dr. Moorheim was on this study, was a constant ER doctor saying, there used to be one pill 20 years ago, and now there's all these. Sometimes it's just that critical information that consumer might not know.
Don't know my medication. I take a blood pressure medication. I don't know what it is. I don't know what the dose is. I don't know this. I don't know that. So and again, it doesn't tell you that they're taking it, but it gives you one piece of information. At least it's the way
They travel with baggies.
some do, some don't.
And I guess to your point earlier around like sometimes maybe they're supposed to take it every day, but they're really only taking it. They say to them, oh, I take it every other day, but all that information can help sort of close the gap.
Some just can't afford it. They just don't.
Again, this is about a report that's going to go to the General Assembly that will allow them to consider legislation in the future. As we know, during that process, it will come back to us again. There will be additional discussion that comes back. This is not, we are not making a recommendation that they proceed with development of legislation.
To your point, I was going to ask, I have two sides to this. One is, 81 people came together, hopefully not at one time, but if they did, I can't imagine, to do this study, right? You all guided what you hope would come out. Does it, whatever we do, it's going to go now, it doesn't go to the Secretary of Neal, it goes right back to some group at the General Assembly? Is that what happens to it?
Yes, so now this.
And who would that be? And then what, does the Secretary pass judgment on this at this point?
No, those 81 members, there were some active participants, but we were very transparent throughout this process.
Weren't a lot of administrators, I could see, looking at the list. So when you talk about costs, and that's the other part, I think, and I might got it wrong, but I looked at the background of this massive document, and something about Nebraska. And Nebraska, it was shared between the hospitals and the insurers. They were requested, they put up money. This country
kind of has insurance advantage.
Well, hospitals are paying either way. So do we have to put in there a recommendation on funding?
So it asks us for a recommendation. We could choose to omit it, but I think to your chairman's point of view, it's a perspective. Absent that, it's hard to know. It's hard to know costs, but we yield.
If you look at assessing every doctor in the state, the hospitals do, and it's easy to get the cost commission to jack it up, and then the hospitals get criticized. So, I suspect there's no alternative, and I'm not criticizing, but it's just fascinating to me as we're doing these studies, and also the hospitals don't pay for it.
It's a relatively small amount of money, and it's not this is the work group. This is the work of a work group. What's that?
The point though is that 750 is just a number they threw out. We don't know if that's a real number.
We don't know if it's a real number or not. This is a preliminary assessment of what could potentially happen. This is not legislation. This is not likely to lead to legislation, I don't think, based on the trend that I'm hearing. And I think that we have to weigh that, the degree to which we micromanage the language in this that came forth versus the degree to which it represents something that we can't back away from as opposed to an initial draft of something. So there will be lots of additional opportunity for us to weigh in on this as it gets developed. I can assure you that if this gets down to the point of a new tax on the hospitals, the MHA is going to have somebody there to weigh in on it, and it'll come back to us again to discuss again. I think we could certainly decide that we want to withdraw any language around from the report around a preferred funding source. That might be an easier way to handle this moving
So is that what you're, I mean, the notion is that this has come out of the work group, and how much are you thinking at this point we should add or subtract content at this point?
How much, I guess the other way to ask that is, how much do we micromanage what we ask the work group to do? when it does not represent a definitive statement on the part of the commission, but
Right.
rather represents the product.
I guess I am,
the product of a work group.
right, I'm not exactly, a hospital guy or anything like that, but I am concerned where you only put really one or two options on the table. It does leave the impression that you've examined the options for funding and these are your two preferred. Whereas I think we could say something like, much of this is Medicare and Medicaid, that maybe should be general revenues from the state. Unfortunately, our friends in the insurance company, maybe some massive active premiums, because the patient is getting the value here. This is, you show up unconscious and, the right thing is done, not the wrong thing. So I'm sensitive to this notion of why hospital gets taxed rather than a broader based.
I can assure, if we get to the point where hospitals getting taxed, I'd be actively opposing it. I'm not arguing in favor of hospital being taxed at all. I'm just arguing as I'm asking the question, how much we want to micromanage the detail of the report that came from a commission that we asked for, that we asked to develop it.
Right.
As opposed, and this is language in a report that we're micromanaging at a table when a large group of people did an awful lot of work getting it there. When they're asking for the commission's specific opinion about something, that's different. This clearly reflects the fact that this was a large group that we put together, that we commissioned to say these things.
Mr. Chairman, in all fairness, if we approve this, we're approving as a thought process.
Yeah, we could also in the cover letter state that at this meeting, we objected to those specific things. That's another way we've handled these things in the past. The report is the report. I don't think we're claiming that it's our report. We describe where it came from.
Could we vote it down?
Yeah, we could vote it down. We'd still go through, right?
I think, it's, the Healthcare Commission was asked to convene this work group. It would be, we could send it back for further,
change the result.
send it back for further discussions. What I was going to suggest was funding should be based on an equitable distribution of cost. That's basically what we're saying there is that take it out of the Maryland Healthcare Commission's budget because we assess hospitals, insurance companies, practitioners. But I think that a more general funding recommendation could be added as opposed to something on a specific entity without damaging the flavor of the report. But I think ultimately it's the commission's report. And we've done this, as you observed, where we've sent a letter in that nuanced the commission's perspective versus the work groups. Previously, we've also tinkered with report language, which is not acceptable. I think either approach would be appropriate, but I think we shouldn't. I think Howard advised against rejecting the report.
Yeah. Can I? So just to follow up on that suggestion is, we can say we commissioned a work group. This is the report that they developed. When the commissioners reviewed the report, they had concerns about X, Y, and Z, and recommended the following changes. We do that in a cover letter. Certainly, the cover letter is going to get more attention than the report itself. So we sort of trump what's in the report.
Do you
To
think
say that we
rather than the
commissioned a work
executive
group.
summary?
What's that?
I don't, and maybe it's just our different styles. I tend to not read cover letters. I go right to the executive summary. That's what, and then maybe I skim some tables, to be totally candid. So I'm a little, you brought up an option before, which I is to say something about, we don't see these funding mechanisms as preferred options or just stay moot on funding. And I guess I would be more comfortable with that than letting it move forward with only a vague one about government funding and then sort of there's a kind of an outline for a hospital-based funding mechanism. I don't think that that's fully developed. I don't think you're not giving this committee or whoever the members are kind of their full options of what funding mechanism. So either give them their full options or stay quiet about it.
So take it out of the report,
I think you should take that out of the report because $750,000, what we already said, we've come up with that number just as a ballpark.
Well, our staff is quite excellent.
Okay, so we don't know if that number is accurate, and it says very clearly in there that a model would be distributed among 47 hospitals. I don't think we should say that. I think we got to be silent.
So let me ask this, since it's a work group product, how do we feel about sending it back to the work group and asking them to, if they're comfortable removing that? Is that an option for us?
Mr. Chairman, that is indeed an option, short answer. I might suggest that we could, to some of the commissioner's point, is just say that, is take out assessment on hospitals and to leave it very vague, that the amount proposed to determine the cost is the amount, and stay silent on who it might be assessed to.
You feel comfortable?
I think the work
based on the work group supporting that. Okay.
Yeah, and we would.
We still have about another 6 months before our deadline, right? Back to the assembly.
Well,
it's like a January 2020.
So at the end of the year, correct.
Yeah.
But we would ordinarily, after the commission approves the report, we submit it in that following month. Sure. But we would absolutely send the report back to the work group just to give them another peek at it, if you will. And if there are any concerns, we would identify and address them.
So can we do that? So we can edit the language, take that out, send it back to the work group, make sure that they understand what we did to the report, and then we have time at that point to submit if there's a.
Correct, unless you wish us to bring it back to you all for another review.
Only if they object to that thing, because then we have two separate views, one of the commission and one of the work group, and it's only fair to the legislature that we declare that to them.
I'd like to make clear that the commission is not unanimously opposed to the idea of hospitals paying.
Yeah, I haven't heard that the commission's opposed to the idea of hospitals paying for it. I think the commission's opposed to the idea of listing one source of funding for the.
Yes.
That's right.
That's not the full options available.
I think there is, with perhaps one exception, the commission is supportive of payers paying for it. But
Either way.
maybe two.
There might be
Sorry.
two.
Well,
Seriously, 5 minutes.
I'm just
out next door
I
asking
just
for
have
$11,000
just
in their
have to be
budget.
careful about
Somebody's gonna pay
representing
for it anyway.
too closely your own position.
Yes.
I get it, but what I'm hearing from the group, if I'm not mistaken, is that they're uncomfortable with one option being listed here. And look, in my personal, I'm uncomfortable with hospitals paying for it too. I mean, but that's not the point. The point is that this is the product of the work group, and we have a responsibility to make our opinion known too.
The work group just has no other options. This was the only option that was out there.
It was a small piece of what they did.
So let me be fair to
They didn't
David,
focus
who
on
is
that
taking,
issue.
if I may. So I did receive a draft of the work group report. And I said, this is that when you send something to the legislature that has a cost, and you don't provide a funding source, it's met with snores. So I did direct David back to the work group to come up with a funding source. So he initially was maybe consistent with the commission's feeling that we not do anything. But I think I would still argue if you have to provide one or more options, otherwise it's met as not a serious proposal.
And having been the target audience of these things, I'd say you don't supply one. One implies we all talked it over and we got a good idea. And
that's fair.
Prescription drug program. Yeah. Why not? Why are we creating another infrastructure? Why not combine the two? Controlled and non-controlled.
It would combine services.
Yeah, so they would parallel each other, but to the point the commission raised, our language in the report itself, in the summary section, we just merely say an option, but we can take out the word hospital.
Okay.
Just leave it silent. Just say.
Just to understand what Ben just said clearly, is it when the draft originally came from the work group, it did not have a funding option in it?
It was silent.
And we added it afterwards?
We added
at the staff level?
Correct.
So that makes,
is this your idea or I mean, our idea, or is it theirs?
This is my idea that we have to submit a
Gotcha.
report. You have to provide it.
You should,
One
or at least you should.
And then we make the report available back to the company. Okay.
So
I'd like to see the study they did. It sounds like the study doesn't prove your premise.
no, there is no study.
is there
I think it was a study that showed all these medication errors.
This is just based on data available in Maryland.
Medication errors are the nurse gives the patient the wrong medication. It's not, wasn't on your list. That's not what the error is.
Yeah, so where we make reference to adverse drug events, that we've included the literature source, and we try to keep that at more of an academic level. So we didn't do any of the empirical field work on that. We relied on literature review.
Well, if you want to be scientific, you have to study comparing people on repository, people not repository, to see the outcomes.
And we engaged physicians.
Make a quick question. So, assuming we remove the language around funding, if you go to the second, or I guess that's the third main bullet, rationale and benefit to hospital, this program would have benefit to people other than hospitals, right? So that might be a place where we update that language as well to say access to medication records for other than hospitals.
Correct. And in the report, all we did, so we're giving you, you're seeing the slides, but they're not exact quotes from the report. In the report, we use the literature to attribute a percentage, what the literature says, percent of those costs impact on hospitals. And that's all we've done.
There would be an impact on a wide variety of people.
Yeah, so
Hopefully at the end of the day, patients. Otherwise, it doesn't matter.
And that is the emphasis in the rationale in the beginning around patient safety and not just hospitals, but everyone who could stand to benefit from the information.
To move along, I motion that
Please.
that we approve the reports with the suggested recommendation that we remove the funding source language as currently stated in the report.
Including the
But what
rationale.
about Ben's point that the legislature will roll their eyes?
I think our job is just to.
It wasn't our idea to generate the report.
Yes.
It wasn't our idea to proceed down this pathway. This was,
And I feel like a full discussion of all the sources is just kind of a boondoggle that we don't need to go down for the dollars here.
so I have a motion.
Motion to move the report along to the next step, barring the changes, removal of the financial language and updates to the benefits to.
Do I have a second?
Second.
Can I ask a question about what the intent is?
Yes.
I like the dollar estimates. I think would be helpful.
Just
Not
the
necessarily-
funding piece, not the cost piece. That's
Okay.
fine.
Cost is okay.
Additional discussion about that motion.
First of all, it's good. We just want the assessment of the hospitals and
And the
financial
rationale.
costs.
So that's the motion on the table right now. All in favor?
Aye.
Opposed? One? Two. Two opposed. All right. Thank you.
Thank you, Mr. Chairman.
Options provided by the center. I agree that providing something to the General Assembly about a multitude of list of options is not what they want.
I understand. I just didn't add
So as said, I disagree.
All right. Ladies and gentlemen, welcome. Agenda item number 7, I believe. The Maryland model, experience and progress in implementing value-based healthcare.
Great.
Katie's not here.
Katie's not here. She sends her regards.
My notes are incorrect. Chris Peterson, HSCRC's Principal Deputy Director.
Yeah.
And
And Tequila Terry, Deputy Director, Payment Reform and Provider Alliance Team.
we'll be providing an overview of Maryland's all-payer model and the total cost of care model. These models are the foundation for value-based delivery system reform efforts in Maryland with the goal of providing more coordinated care, including for chronic conditions, reducing healthcare costs, and improving quality of care. In addition to providing an overview of these models, HSCRC staff will discuss areas where HSC and MHCC are collaborating on policies that impact the models. The floor is yours.
Thank you, Mr. Chairman, Commissioners. Again, Katie sends her regards, and so I brought Tequila Terry. She's been here for all of 2 months, so all the hard questions go to her.
Thanks, appreciate that.
I was here, I think it was about a year or so ago with this commission, and just wanted to, I know you've got some new commissioners, but just to provide a general update and not to steal Tequila's thunder later in the presentation. But I do want to personally acknowledge our collaboration with the MHC staff, with Ben and his staff. To be able to tap their expertise has been helpful for the things that we are all
trying to do in Maryland to improve health. And so that's great to have them as part of this. So I know this is the last agenda item. I will try to be brief. As you see here on the agenda, we will give some overview of Maryland's all-payer hospital all-payer rate setting system, and then talk about the total cost of care model, some of the collaboration. So this really gives you an overview of the evolution of the model. And can I just say for the record, what we do in Maryland is not a 1970s era of price regulation. That is the way it was in the 1970s, as you see there, but as we'll talk about, we are under global budgets for hospitals. But what it does mean is that since 1977, all hospitals charge the rate that we say, and that is the same regardless of payer. There's also confusion. Folks think that means we say this is the price for all the hospitals in the state. That is also not true. It just means that if you go to a particular hospital for a particular service, all payers are going to pay that. They're going to see that charge. That charge may differ from Frederick Memorial to Johns Hopkins, but when you're in that particular hospital, the rates are the same across all the hospitals in that hospital for all payers. We did do basically a test run, if you will, of a global budget for hospitals beginning in 2010. And so it was 2014, we went to the all-payer model with CMMI to put all the hospitals under a global budget. That was a 5-year agreement, and now we are in the total cost of care model. Just to tout the next slide, some of what we see on the right is if you talk to hospitals in any other state, this is what they will be known, which is the fact that Medicaid and Medicare pay below cost, and then private pay pays above cost. So you will hear the commercial insurers complain about that. And we do not have that kind of scenario in Maryland because all payers face the same charge. What this results in on the left, we avoid this cost shifting. And so we have cost containment for the public, equitable funding for uncompensated care. It provides a stable and predictable system for hospitals. All payers fund graduate medical education. There's transparency, and we in Maryland are then a leader in linking quality and payment together. So to get down a little bit more into the weeds, so since 2014, hospitals have been under a global budget. That is all general acute care hospitals, and that is based on essentially 2013 is the base year, and then from there our commission sets an annual rate update, and there are adjustments for variables including population growth, but then also pay for what you want to get. And so if we want reduced readmissions, we pay for reduced readmissions, penalize for higher readmissions, hospital-acquired conditions, etc. Outside of the state, this would make people's heads explode, but it's under the hood, so maybe too much detail, but it still operates as a fee-for-service system in terms of how hospitals get paid. So in order for them to hit their global budget for the year, we actually give them the flexibility to dial their charges up as volumes go down, and vice versa. So that at the end of the year, they have to hit that global budget amount, and they are penalized if they come in too high or too low. I will note that sometimes we use the term population-based revenue. If you actually look in the total cost of care contract, there is no reference to a global budget, but population-based revenue, which to some extent is actually a little bit more reflective of what is actually done. It's also because when we went through the clearance process and folks were seeing global budgets, and apparently our federal partners had to talk with the Office of Global Health and explain it to them like it doesn't have anything to do with them. So trying to keep things simple.
Chris, do you want to take questions as you
go ahead.
Or,
All right.
okay, so why would you penalize them for coming in too low?
So that's a fair question, right? Because you say,
yeah, your budget is 20 million, you come in at 18.
Right.
Sounds okay.
Right. But they would end up making it up in the following year, and we have annual tests, and so if they make it up, which we think is the right thing to do, then we really want them to manage their costs well. So let me say it like that, in terms of how they manage things.
So do they get, if they, in the 1820, you know, kind of, they only came in at 18 when you budgeted them for 20. So are they given kind of an extra 2 in the next year? Is that what you mean by it?
Yeah.
Okay, so they have kind of total area under the curve. Okay.
Yep, exactly.
Okay. Yep. Got it. Thank you.
So high level, you know, the analogy that I give is in the rest of the country is providers are holding down, payers are often trying to hold down rates. It often means providers are trying to crank out more volume, so it's trying to go up a down escalator. And so this is really trying to get off of the volume incentive. And we're, again, trying to incentivize what we want to see, which is reduced readmissions, reduced hospital-acquired conditions, reduced ambulatory sensitive conditions, better managed internal costs. And so we'll see some of the results coming up here. So if we can go to the next slide. So the first column of numbers shows what our contract with the feds required the state of Maryland to do. And then actually you can just click again, Tequila. The big one from the federal perspective was that we, the state needed to save Medicare $330 million cumulatively over that 5-year period. We have clocked in at 1.4 billion. So that made our negotiations to renew this easier than it would have been, noting that the first contract was approved by a Democratic governor and a Democratic president, and now we are under the Total Cost of Care contract that was approved by a Republican administration, state and federal.
Can I ask a quick question?
Sure.
So without this, where would Maryland have been on their Medicare cost above at the national average?
So that is a hard question to answer because I think what happens is folks think, oh, if we just threw Maryland hospitals into that, what would happen? Because we've been under essentially all payer rate setting for the past 40 years. And so it's a hard counterfactual to address because hospitals around the country are doing things in the way they code, for example, around GME, that we do not do in Maryland. And so I think there would be a shock to the system. And I think some of the budgeteers look at that and say, oh, if we just moved Maryland, that would be savings overnight. But that would quickly dissipate as hospitals say, okay, we're not on this anymore, we're on this. We're going to start changing the way we do things. Better reporting, for example, on the wage surveys that Medicare collects, a lot of things. So I think there's a big number that people throw around, which is not accurate. And I think all told, what we want to do is I think we are a little bit above our peers. And so what we want to do and what the requirements of the next 5 years requires to do is to get below our peers in states.
Basically, we're above, you think that we're above national average on our Medicare cost per?
Yes, we are. Right. And so some of the other things to note on this, the last, so all payer reduction in hospital acquired conditions, we pledged to reduce that by 30%. We've reduced it by 53%. Some of that is probably coding related to ICD-10, et cetera, but we do think that that is real. We've met that. Readmissions reductions, we were actually above the nation in our readmissions rates and are now at or below. And we were required to get 80% of hospital revenue under global budget, and 98% is now under global budget.
Can I ask a question about the readmission reduction piece? Because when I see these substantial drops in the number of readmissions that we're in, we've certainly seen data nationally that suggests that as you drop your readmission rates, that your mortality rates for certain sensitive conditions go up. What are we doing to monitor that?
This is exactly why in the new contract, we did not agree to any particular hard target around readmissions. So what we said is, we're not going to backslide, and we need to figure out a path forward on readmissions. Exactly to your point. If volumes in the hospitals are going down, the people that you see are sicker, aren't you going to expect to see higher readmissions rate, all things being equal, et cetera? So that is something that we are working on to acknowledge our federal partners are on the same page. We all get it and are on the same page.
Right now, in the readmission reduction incentive program that we have in place, we still have some pretty harsh penalties around readmissions.
That I think is true, but that would be our quality team who's been working on this, and this has been part of the work group discussions about what's the right thing to do here. Yeah. Okay. Next slide, I just want to briefly hit the total cost of care contract was signed by the governor and the feds last July. So next slide, just very briefly, on the left, you'll see that the focus of the all-payer model really was on the hospital piece. There was some that had to do with across the care continuum, and we've been working on that, kind of making an evolution. It's not like there is a magic moment that happened on January 1, 2019, but as part of the evolution, want to focus on care improvements across the continuum, which is, again, why your staff are involved with us on some issues and are very helpful. Okay. Yeah.
Go back a slide. Go back a slide. Can you talk more and move the lines across it?
That one.
Yeah. This one.
The one right after the sign. It's not 11 R. That one.
Yeah. Can you talk a little bit more in regards to hospital quality metrics?
Hospital quality metrics there are quality metrics around readmissions. There are quality metrics.
To improve them, is that?
Oh, sure, yes, absolutely. I think it goes back to the chairman's point of trying to improve what we are capturing within the hospital. But then, so you're asking about the hospital piece?
I'm asking about what you're doing to try to improve them.
Maybe reciting some of the metrics that are being monitored.
Right. So the readmissions, I think the chairman's point is right, acknowledging this is where we've come thus far. There are things that we need to do going forward. We have I'm trying to remember the exact number. We have a work group that focuses on these issues about what needs to change. So we also have our impact program, which is about hospital-acquired conditions. So that's a big program where there are also rewards and penalties associated with that. Some of that has been simplified. So there were, I want to say, 50-ish measures, and I think they've tried to boil that down to simplify that. There are measures around potentially avoidable utilization, PQI, so things that are related to prevention. So if there are admissions around folks coming in to have their leg amputated for diabetes, for example, hospitals actually are penalized for that. So there is a long list of things that fit into that. So those are just some of the examples.
Okay, just to point out that one of the topics that's discussed here a lot is whenever we get the hospital quality reports, how sad the state of affairs is that our hospitals are not ranking as high as they really should, especially since the state of Maryland, as far as education, is one of the best and recognizes the best throughout the world, that we should have a higher expectations for hospitals to look at infection control. As a prime example, Johns Hopkins has gone around the world preaching infection control and has implemented in very austere environments, yet in our own hospitals, it's still a problem.
So the hospital-acquired infections metrics that they measure and reward on are an important piece of that. I was one of the biggest critics of those numbers when they came through here, but those have actually substantially improved statewide over the course of the past 3 years since we started looking at them, and their pay for performance. The quality-based reimbursement system does, in fact, penalize heavily for metrics that are above threshold levels and rewards for metrics that are below threshold levels.
That was sort of this, I remember that discussion. That was one of the problems when we saw the CDC, which was a broader range, some of those other infections, et cetera, you could see that there was behavior. If you pay for it, they looked good. If you didn't pay for it, but it was a general kind of quality in the hospital, it was just CDC.
So
We saw
some of it is impure measurement and how you collect this stuff. So C. diff, for example.
But I think we were all surprised that Maryland hospitals were scoring in C's when Virginia hospitals.
Because they were being reimbursed differently for the same thing.
I understand, but I'm just saying, I think we were all disappointed.
And I think one of the points, though, from that is that the measures are getting better for Maryland, so we are improving. And, our commissioners have expressed the same concerns, because some of those are HCAHPS measures, which I did not mention, but those are, so if you're an individual who's in the hospital and you report on what your experience was, we have not moved a lot on that, even though we actually have dollars associated with that. The hospitals will say there's not a lot we can do, to affect that. And that is an argument that happens, but we're still, they're still being dinged on that. ER wait times is also one that I think in the national measures we do look bad on, and is something that we want to. What's that?
That is generous.
Yeah. But that raises a lot of questions about where we should be going, what system-wide can be done, whether that's with the EMS system, what are other policies that we need to be thinking about strategically to address this.
Who makes up those decisions about penalties for certain conditions? Like you just mentioned an example, doing an amputation on a diabetic, the hospital gets penalized for that?
Yes.
Can you explain why?
Well, that was, again, this has to do with, we want to make sure that, so there's an argument, which I think is what you're going at, is should the hospital be held responsible for those kinds of things? What we've been saying is that hospitals, you need to do more than just focus on what comes in your walls, and to have a better footprint, involvement in the community. I think it goes back to Commissioner O'Grady's point that to the extent that hospitals have been held accountable for that, it has affected change in the community to help deal with some of these issues. It's not a silver bullet, but we have seen movement in terms of where hospitals are investing in these things.
So from the penalties are around observed to expected ratios for complication rates in certain senses.
No, it's talking about a patient presents with a dead foot, diabetic. Hospital gets penalized because he gets amputated.
The attributed hospital gets penalized in that because that's under the total cost of care.
I don't get it. I don't understand that. Why the hospital get penalized?
Is the
or a patient comes in with urosepsis and within 30 days gets admitted with a heart attack. In 30 days, hospital gets penalized.
Right.
What's the rationale there?
Well, so I can give you, let's say, an example of if this problem was really upstream, right? And is it something that can be fixed? What we've seen is hospitals start to invest more in the community to ensure that, these things are better managed.
They can't be blind to non-compliant patients. There's an absolute percentage of non-compliance in the community. Every one of these non-compliant patients, whether it be 2%, 5%, 10%, they come in with a complication and the hospital gets penalized.
Yeah, it's a fair point. And when, Commissioner O'Grady was talking earlier about having a third party do evaluations. So the feds have paid for evaluations of our model, and the results have been good. But this is one of the areas where hospitals have said we've got a problem with non-compliance. We're being held accountable, but we really can't do much about it.
You expect no complications from surgery, central lines?
I think it's the chairman's point that it's observed to expected, and you're trying. It's not that there is zero, but it's trying to make improvements.
And the argument, I hear what you're saying, and I felt it, but the argument against that approach is that under the ACO models throughout the rest of the country, the hospitals have been accountable for the costs associated with care in patient populations that include groups of people who are compliant and groups of people who are not compliant. It's the same thing here you're talking about. You can't be when you're accountable for a population, you're accountable for a population, the good and the bad within it, and you have not a complete ability, but at least a partial ability to modify the health of portions of that population in ways that decrease the overall cost of care within that population. There's going to be an expected number of patients who get amputations with diabetes. But if you can figure out how to globally improve the health of some of the people to decrease that rate somewhat, in this model you make money, and if you can't do it and you don't invest to do it, you'll lose money in that model. The proof is really that there's been success, that we have actually moved the needle in many of these metrics along the way. Not all of them. You're right. And I had a patient with a hip fracture just a month ago that I took care of. He did great. Got out of the hospital within 3 days. Went to a skilled nursing facility. Spent a week there. They did a pretty crappy job with him, and he wound up with severe constipation and diverticulitis, and wound up admitted for 4 days. We get a penalty for that because he was discharged within 30 days from our institution, even though the skilled nursing facility. We have to learn over time which skilled nursing facilities to partner with, how to monitor patients within those skilled nursing facilities, and take responsibility for the things that we have traditionally felt were not our responsibility. And we're not going to get to 100% in fixing it, but if we can move the needle downward, we can share in the savings. And
Just a quick, and again, maybe these are native slides, but conceptually, we're going from, because we talk a lot about hospitals, because that's who you're regulating. And you're putting the pressure on the hospitals to go outside the walls and do other things to get incentives back, okay? So my point is that when you're looking at this global budget, basically a total cost of care for the model, and the hospital gets a certain amount of dollars, and they start stepping outside the walls, which there's costs associated with that. They have to do additional partnerships, use cost sharing models where people are rewarded outside the hospital setting. In the rate structure, and again, maybe I'm asking too much technical, how does that actually work? So for example, let's say your overall admissions drop and your overall number of patients served is less at the hospital setting, but you've invested so much more outside of that. How does that bring back into the rate side? How do you do that?
Well, under a global budget, the theory is that they keep the money.
Okay.
And then they are able to take that money and invest it in other.
And they just have to show you that? They have to show you that investment? They do
Yeah,
that just through?
we actually have not, to be honest, done a good job of capturing that piece, but it is something that is high on our agenda.
I think
Because
you'd
what-
have to figure out a way to, I mean, there's going to be data inside the hospital that there might be admissions are lower or outcomes are better, but you don't necessarily see that outside because you don't have any regulatory authority outside the hospital walls. So, to me, that would put that responsibility back on your physicians, back on your nursing homes, back on your urgent care, other types of facilities that the hospitals would probably have to capture that data to get back to you. So it just seems.
Or is that just the rough justice of this? That's sort of to
Well-
Jerry's point that you better do something about your amputee, your type 2 amputee, or your, any diabetic amputee. And if you have an extra $5 million, you better figure out something more than a cookies and tea support group every Thursday or something. You need a real program here to address it.
Yes, so definitely that, and I'll give an example where a hospital was getting a lot of admissions from a particular assisted living facility. They were showing up at the hospital all the time. If you're under a volume regime, you're like, thank you, Jesus, I'll take them. Instead, this hospital built a clinic in the assisted living facility to manage folks and keep them out of the hospital. So those are the kinds of things that we actually want
So
to
my
occur.
point there is, so the hospital's admissions drop, global volumes drop,
Keep the money.
you keep the money. So how do you know when to keep the money because you're managing care well, as opposed to keeping the money because you're doing nothing and volumes just drop? You know what I'm saying? Because you could have outside.
So when you keep your emergency department on yellow alert full time, and the ambulances get diverted to another hospital,
Yes.
your volumes go down.
Sure.
Right. So how do you take that? How do you take those dollars out? Talk about the rate at which you take them out.
Right. So this is a challenge.
Okay.
It is a challenge. It's something that we're working on. We have a lot of data whereby we can look at, well, we have a lot of Medicare data, let me say it like that. So it's Medicare data, we got everything, and we are able to figure out when services shift outside of a hospital. If things shift outside of a hospital, we generally take 50 cents of the dollar back from the hospital. That's one. Two, and what I'm about to say is actually on an all-payer basis, has to do with what we call a market shift. So to your point, if you just like
hey, go over there to that hospital. We have all of the data to say, it went over there, that's where the money's gonna go.
Even across state?
How much of it?
Not across state. Actually, we do have some data we look at across state. So we have gotten data from DC. Again, for Medicare, we got everybody. So we have intel on that. So let me say it like this, we will get insights from outside of Maryland that we can then use to adjust local budgets for shifts like that.
So if you decide as your hospital that you're gonna stop, you did 100 total joints last year, you're only gonna do 60 this year. You're gonna shed the cost of 40 of them. How much revenue are you gonna take out?
So if a hospital stops doing a service or is doing things like this, they're required under their GBR contract with us to let us know, and we take out 50 cents on the dollar.
50 cents a month. You keep half the revenue, even though you took out,
100%.
well, you don't take out the fixed expense.
Right.
You take out 100% of the variable expense.
Exactly. That's the theory. Yep.
And have there been hospitals in the state that have substantially decreased their volume over the course of this 5 years?
Yes.
2014.
And a lot of it is moving from the inpatient space to the outpatient space within the hospital. So that's a source of savings, but then it is also from the hospital outside.
From the hospital to other hospitals.
And that we get, yes. And then when that happens again, we get that.
But you only get half of it.
We only get half.
We take half the revenue out.
That's right.
So that's important for commissioners to understand that there are certain critical access hospitals that remain open all the time. They're not traditional critical access hospitals as defined nationally, but they're functioning as critical access hospitals. And those hospitals have seen growing volumes over time. And other hospitals have seen lowering volumes over time. And the balance of the GBR assessment between the two has been incomplete, I would say. But I think my colleague on the other commission would say the same thing.
Has the HSCRC acknowledged that Harvard study that shows with this readmission focus that mortality rates have increased for pneumonia and stroke? Because people so afraid, the ER docs afraid to readmit patients, that mortality rates are up.
So yeah. I remember it being discussed. To be honest, readmissions isn't my wheelhouse, but that was discussed and is something that.
Is it an absolute penalty, monetary amount? Is it like $9,000 penalty for readmission or something?
Somewhere up to 30,000.
For readmission?
I don't know, but we can find out.
Each hospital has a different rate for readmissions, for the readmission penalty, but the readmission
I'm
reduction.
leaving over to Maryland.
Yeah.
My house.
It's a smaller number there, but at the medical center it's higher, at Hopkins it's higher. The readmission penalties are higher at the bigger hospitals where the GBR base is higher and the fixed infrastructure cost is higher. But it's the readmission penalties are very high, and that has focused the institutions on practices to reduce readmissions. And as I pointed out earlier, the downside of that is if you reduce readmissions too much, you can increase mortality, as the literature has shown. And that's a concern. And I think there are monitors in place to make sure that we're balancing those things, but they're always incomplete, right? At some level, you have to trust that the physicians at the ground floor level are making decisions that are in the best interest of the patients they're taking care of. And that's a trust that we've maintained. We have to be able
So which
to run
one's coming in too low under budget, too high above budget?
I think the penalty's a little higher for going too high. Yeah.
Well, if you come in too high, you just don't get any more money, right? If you do,
And if it goes above a certain level,
What's the penalty for too low? Just the next year you lower their GBR?
Say that again.
What's the penalty for coming in too low under budget?
I forget.
There's a penalty.
Yeah.
So if
But
you
it's like
become efficient, like you said,
.some%.
take care of these diabetics as an outpatient, drop admission rate, you actually can reach a threshold where you get penalized, correct?
No, because you can dial up the price if the volumes.
but there are
To a
thresholds.
certain point.
There
Only
are
one or two.
thresholds. There's a 10% window.
Oh, yeah.
If you get below the 10% window, then you're at risk for losing revenue based
So
on.
it's different things.
I see a
One
catch
is
22 here, that's all.
Yeah.
Can I ask you a little, because you brought up the point about kind of, you can reduce on the hospital side, but some of it is squeaking out into an outpatient, and some of that is fine because it's a lower cost setting, et cetera, et cetera. But now as you transition from a hospital-focused approach to a total cost of care, can you talk a little bit about, you know, some of those savings that you showed on the hospital side, and some feel for how much of that is money was still being spent, but just in the other parts of the system, versus what you think is total reduction, you know, total savings across the system, and sort of how do you guys take your game to the next level here, where you have, now you're responsible for the whole spectrum?
Right. So again, some of the biggest savings has been from moving from inpatient to outpatient. We've captured that. But to the point about how do we move to the next level, it kind of goes back to the chairman's example. So he was talking about somebody who goes into the SNF and, you know, bad things happen, get readmitted, et cetera. So we actually, and this is what Tequila will talk about in a minute, but we have a new program that began January 1st, ECIP. And what that does is it says to hospitals, okay, you got folks who are coming to your hospital and they're discharged. We want you to take responsibility on what happens in the 90 days after discharge. If you're familiar with DIPSI Advanced, it's kind of on that model. And so what can happen is that the hospital can actually, if they're reducing what happens in that 90 days after the hospitalization, then they can get a payment. And they can partner with doctors and they can partner with facilities formally, just to say we're partners, and or they can share incentives. I know you're familiar with the MACRA stuff, so the docs who participate can also be MACRAtized and get the 5% bonus. So there are a lot of carrots with that. I will say that we did a presentation to the hospitals who were interested in this and showed them basically an example of the opportunities that the CRISP tools, which are phenomenal, provide. So basically, you got your surgeons, you're looking at this from a hospital perspective. You got your surgeons lined up in a graph, and you can see where they're discharging. How much is SNF versus community versus home health. And there's a huge divergence where you've just got a bucket who just, it looks like they're sending all of them to a SNF. And so there's an opportunity from a hospital perspective. I know who these docs are. I got the data. I can talk to them. And maybe there's a bona fide reason that they're sending all their patients to a SNF. And if that's so, that's fine. But at least let's have a conversation about this. And it's also about the quality of those SNFs. So now the hospitals are paying more attention as opposed to just, you know, I'm not saying they weren't paying attention before, but it raises the bar somewhat to pay attention to what is the
greater
length of stay. Are you just hitting the Medicare max, or what's the deal? And let's have a conversation about how we together can manage the care for those beneficiaries. Okay, so Tequila, I think we're going to.
You had one more question.
If I can ask you. So I guess I'm still thinking of the coming under budget part, because I'm not sure it entirely makes sense. Over time, shouldn't the hospital budgets be going down? Certainly as a percentage of the total cost of care.
Right.
But even going down in inflation terms, like it sounded almost like one of the penalties would be your budget is lower. But as we move things out of the hospital to more efficient settings, and we're approving more ASCs by the day, shouldn't budgets be going down at the hospital?
Yes. So and I recently heard the OMB director on C-SPAN say, so he was a Republican member who said, you know, there were ideas to just slash Medicare, and he said, what's going to be most effective over the long run is reducing the rate of growth. So to your point, that's really what we're looking at doing, is reducing that rate of growth. Our commissioner set a rate of growth that is below healthcare inflation, healthcare spending, Medicare total cost of care growth. And so that is essentially how we ensure that there are savings that accumulate over time under this model.
And I had one more question, if you could, and if you're going to do it later, that's fine. Where do drugs fit in with this? Because I think drugs are getting to be like 30-35% of the total spend, and we talk a lot about readmissions, but actually hospitals are lower than drugs now in spend. So in terms of total cost of care and what we're doing, cost of pharmaceuticals.
Yeah, the drugs are a problem. And so back on the slide, you don't have to go there, but back on the slide that showed the percentage of the hospital spend that is under global budget, it said 98%. That 2% is for drugs because there are new drugs that come out that are very expensive, and there's just not going to be the capacity, we believe, for the hospital just to bear that under a global budget system. But that doesn't put all the drugs there. But when we do the calculations of what an appropriate rate update is for the year, we do spend a lot of time to look at what is happening in the drug space and what is the right level of inflation to provide, both from a price perspective, volumes, et cetera. So we try to take that all into account, and it is an issue. Yep. Thank you.
So Chris kind of talked about several of these points already. So when you think about the total cost of care model, there are really sort of 4 components of the model. So Chris just talked in depth about the hospital population-based revenue. But the other 3 parts are the care redesign and new model programs. And so these are programs that are intended to incentivize hospitals to work with care partners, so to the discussion that we just had, and then they enable those care partners to actually become eligible for bonus payments under MACRA. The population health component of the model is really intended to create programs and credits that are related to improving the health of populations, so widespread population health improvement. And then the Maryland Primary Care Program really is intended to incentivize the primary care portion of the healthcare system, really to focus on the advanced care needs of Medicare beneficiaries with complex conditions. So I'll talk a little bit about the latter 3, but really they're sort of brought together under this umbrella of really trying to transform the healthcare system, get closer to this idea of lower cost, better outcomes, better quality. So that is the intent of the model components. So here we have a spectrum of programs that are under this umbrella of care redesign program. And it's this idea that we're trying to align the hospital and the non-hospital environment. So we started sort of historically with some programs that are now updated, but what you should take away from this slide is that really the programs that we're putting together that are hospital-based are really intended to bring together services and providers from community care, address services that are in the hospital, and then address those post-acute care situations. So to the point Chris made, under the care redesign program, which we refer to as CRP, the hospital is the convener. So they are the leader of the program. They bear financial risk, and they actually get Medicare data so that, again, they can see those opportunities for improvement, understand what are the outliers in care or costs. So that should then drive them to look for opportunities with partners to address those issues. So the episode care improvement program Chris alluded to really is focused on that 90-day post-acute care and identifying the ways that the care can be improved so you don't get those readmissions. So there's an incentive built into the program so that if the hospital, along with their partners, achieve that 3% Medicare savings, they actually get to share in that savings, and then they in turn can share with their care partners. So again, this is part of this care redesign model. One of the other things that we're working on is a variety of hospital-led transformation initiatives. So some of you may be familiar with the West Baltimore EMS Collaborative, and it's a number of initiatives bundled together under what we call mobile integrated health community paramedicine programs. And the purpose of these programs are really to look at how we can engage the EMS community in addressing some of those issues with either long wait times in EDs, or getting people transported to alternative destinations, or getting on-site care at the time that the patient is engaging with that EMS team. And so this is a program that we're studying, or rather we funded. It's a grant-based program to get them started. And so as results unfold, this is something that we think could take hold across the state. But there are a couple of elements here that really, again, are looking at multidisciplinary approaches to engaging nurse practitioners, RNs, EMT workers to really think about creative solutions. So that is an example of some of the innovation that we're seeing coming out of hospital-led innovations. Under the section that we call new model programs, so this gets to one of the questions that came up earlier about how are we moving beyond the hospitals. So we recognize that there is also an opportunity under the total cost of care model to start thinking about non-hospital providers who want to be engaged in new payment model opportunities. And so we're currently working to develop a program that, you know, is referred to as our Enhanced Episode Program, soon to be renamed our, what is it now, Episode Quality Improvement Program, EQUIP. And the idea is that we want to give, you know, practitioners across the state the opportunity to also engage. So we as a state will administer the program, and it'll have multiple tracks that will allow specialty and clinical care episodes to actually be created in a way that they get incentives for improving performance, quality, and outcomes. There will be what we call a convener role. So for those providers who are not capable of sort of managing risk on their own, they don't have either the expertise or the resources, we'll create a convener role that will allow conveners to actually take downside risk and aggregate it across sort of a group of providers that they'll be working with. They will also be able to provide expertise and training. So this idea of a convening resource really is something that we think is going to be important to bring the private practice practitioners into the mix. And so we're anticipating that this is going to start January 2021. We're in the process of designing it now, working with the federal government to make sure that it's designed in a way that will be supported, that again, it'll give people credit for those macro bonus incentives as well. And at the outset, we're thinking it will be episode based. We're thinking we're probably going to start with 3 episodes, very similar to what the federal government has designed in the federal Medicare program. And we're being very deliberate to make sure that we are engaging voices outside of the state to help us to deliver and sort of design this program. And so we've got a stakeholder innovation group that is made up of a variety of non-hospital providers that are helping us design what this will look like. So there'll be more to come on this.
Can I just a quick one on that one? Sure. So who are these conveners? I mean, who would be willing to take downside risk and sort of try to aggregate, you know, kind of little practices that really aren't in a position to hold risk?
Yeah, there's actually organizations that do this for a living. So in the federal models, there are a couple of organizations. One is called Premier, one is called Remedy, and there are a number of entities that do this across the country. There's also some interest in local organizations wanting to create entities because they have the expertise and they envision that they'll be able to play a role. So we've had some preliminary discussions with a number of organizations that have expressed. We don't anticipate that there's going to be, you know, a whole lot of these, probably less than a dozen, but we anticipate that there definitely is going to be some interest.
And so they're going to be kind of third-party financial aggregate. So like Premier is what, like a group buying, or, you know, a hospital group buying group, or if I'm right, whatever the right name for them is. But so, you know, and those people would be willing to come in, taking risk, and their incentive would be that they think that if they could coordinate better these little practices, there's a certain percentage for them.
Exactly. So they are very good at identifying, you know, who are the practices that are best positioned to be successful. And so they have a whole process to identify, you know, what does readiness look like in terms of a physician practice being able to enroll in a new payment model. And so to a certain extent, it's on them to sort of figure that out. But they will be the bearers of risk, and then they will have to work with the practices across the state to manage that.
Now, would these provide, I mean, are there any protections that these provide, that these aggregators or conveners wouldn't, like someone like Premier, they wouldn't say now, okay, you're all in our new network, So now you have to purchase all your supplies through the mothership? Is there anything where, I mean, I'm a little concerned that you would have entities who would see that this could be kind of a loss leader, but boy, you'd pick up all these practices and you'd either be able to use them as a satellite to get them to a particular hospital or whatever. I'm just, you know,
so
thinking about some of the times we've designed things and then we end up with
the
this sort of.
use of them as a satellite to get you to a particular hospital would be a kickback.
Okay, but I'm just saying, so suppose you're, I mean, you know, it's a big supplier of medical supplies. So now we say, here's our 300 physician network that we're willing to convene for. But, you know, part of it is we really would like you to use our, you know, this other line of our business. I mean, and there's just, I mean, certainly we've seen throughout Medicare payment, this constant that we sort of have a nice design and we didn't think of the loophole that we forgot that they drove a Mack truck through. And now all of a sudden, you know, PBMs are making money for higher cost, not lower cost drugs or whatever.
This is a model that's already in place.
Okay. I'm just saying, who are these? You just caught me off guard. Who would be willing to go in there and sort of think, I want to herd cats with a bunch of individual little practices?
Again, they're already doing this.
Okay.
In the bundled programs for the feds.
They're
So
also-
for them, it's like, yeah, we got this. We know how to do this. We do this on a day-to-day basis. You're doing the same thing in Maryland. We get it.
The practices individually have the ability to do this also.
They could do it.
And in the context of practices supported by CTOs in the model, in the current model we have, it's much more feasible to suggest that the infrastructure necessary to control that episode of care completely or to influence that episode of care, better stated, perhaps, is greater. And that we're moving towards the ability for the individual practices to do it. And once the individual practices can do it, their willingness to sign on with a big bundler who's out there and costing them more money through the supply chain, it goes down because competition controls that.
Yeah, and I think that's a really important point. I think what we're trying to do is create flexibility, recognizing that, you know, practices are going to be at varying degrees of readiness. And so for those that want to participate but may not have the internal infrastructure, the know-how, we wanted to be able to have resources available. But for those practices that say, nope, we got it, we're solid, we know how to do this, so be it, you can participate as well. So we're trying to create a model that allows for, again, varying levels of readiness.
So with the entities that you mentioned, Premier and Remedy, they seem quite different organizations. Remedy, particularly as the BIPSI, finance.
So I think they just have lines of work. I mean, you're right. They do the supply chain stuff, but then they also.
Right. I mean, is that something that historically national organizations have been kind of reluctant to plug into whatever the Maryland model was because of its uniqueness?
You can't negotiate for the hospital cost on it when you do it. If you're the outside.
For that reason, would they be able to put the hospital component of this at risk as well, or would this be, as it has been in earlier models, only the quote unquote Part B and Part D?
Yeah. So the reason that Maryland has been excluded from certain models nationally is because of the GBR interaction. That is why CMS is essentially delegating it to us to figure out, okay, you all design the episodes, you figure it out, you do the math. To your point, in order to account for that GBR effect, we can give credit for utilization reductions in hospitals, but it's not 100% because we do have to take that other piece into account. The other thing is that, to Keela's point, we're just trying to create a marketplace here, make sure that folks know that, it could be a CTO who does it, could be an ACO that does it, could be a Remedy Premier, and it could be, MedChi. And MedChi could say, you know what, maybe I don't have all the bandwidth, but maybe I should partner with somebody like Remedy because they do this and the two of us together can do it. Again, we're just trying to create that market and opportunity.
Yeah, and it's still early on, and so part of this is continuing to have conversations with interested parties. Our stakeholder innovation group is a really good place for us to sort of bounce ideas off of people in the community to, raise concerns if they have them, or let us know, does this make sense or not? And so we're being very deliberate about getting that engagement as we design.
So who are the patients? So Medicare.
For this, yes.
Can you just, the episodes triggered in hospital outpatient department? Why
That's just-
hospital outpatient department as opposed to any outpatient department?
So, sorry, just to be clear, so we were, how to say this? It's easier to get things approved by CMS if it's a copy and paste of something they're familiar with. And so we are starting with 3 episodes that are triggered in the hospital outpatient department that mirror the federal.
Which episodes?
It is stent, defib, back and neck surgery. But
why is back and neck surgery triggered in the hospital outpatient department? It almost never is. That comes out of doctors' offices, non-hospital outpatient, unregulated outpatient department.
So this is where I'm not a clinician. So we were just copying and pasting that. But let me just say, what we heard from the feds was, that's great. We like that you're going to do these 3 because we're familiar with them. So do that, but we want more episodes. So we are actually exploring more episodes. We actually, at the last stakeholder innovation group meeting, Care First presented and they talked about where they're going with episodes. And they said, one of the challenges that the Blues have had was when they purchase something that's kind of a black box on the episodes, clinicians aren't really comfortable. They don't know what they're dealing with. And so they've pointed to Prometheus because it's open source. So that's something that we are exploring to increase the number of episodes.
Well, in terms of, I guess, just trying to mirror, think about what the Fed's logic would be, and that would be not kind of where the case was generated. Your point about physician office, it would be more the idea of that you keep showing up in the outpatient department because I'm wondering whether the kind of episodes we're talking about for this would be kind of Jerry's point about the person who's coming up on an amputation. I mean, that's bad self-care over decades.
Those typically aren't under a BPCI right now.
Right, but I think your point is that should we design episodes that are more chronic care? And so rather than having a 90-day episode, you look at a 1-year episode triggered by,
Well, I'm just marrying, I think you answered it well, but this frustration of, boy, this patient has been, behaving poorly, or however you want to think about it, for a very, very long time. Now we're at the end of that process and you're holding us responsible. And so how would you, this seems to me an intervention you could get because they're starting to take a downturn. You're seeing them more and more. And that's, be great if we could do it at diagnosis, but that's not happening.
The challenge with some of those longer term ones is that the amount of risk that you're taking a year is much more substantial than the amount of risk that you take in a 90-day period. And from an actuarial standpoint, the ability to manage that becomes substantially less unless you happen you take the competition out of the equation.
Absolutely, and I think that's why we will evolve and start with the easy ones and work our way up from the lower hanging fruit to the higher hanging fruit.
So the other element that I mentioned as part of total cost of care, I'm sure you all are familiar with the Maryland Primary Care Program. We're up to now 380 practices accepted statewide, and I should say Dr. Howard Haft runs this program. But it is part of the model, and it's an important
So
element.
I'm just going to jump in there. The feds run the program.
Sorry, yes, be clear.
They collect the request for application. They make the payments. They choose which practices are in.
Thank you.
And it's 380 out of how many?
Thanks for that clarification.
I'm trying to recall. Ben, do you recall?
380 out of how many practices, or what percentage of the covered population
So
is
I think we were
represented?
talking initially about 5,000 primary care physicians. Initially, about 3,500 physicians applied. About 1,750 physicians are in the program. Is that right, David?
Yeah, the 1,500. And we got 220,000 bennies, which is beneficiaries, which I think we've got about 800,000 statewide. So we've got a quarter of the beneficiaries. So we'll say that 120 more practices, I think, applied at this latest open enrollment.
Okay, thanks.
So the way that this program works is that the primary care providers actually receive a care management fee to sort of, again, take on those additional advanced care management responsibilities for those Medicare beneficiaries. And so more than $60 million will go to the primary care practices and CTOs and as part of this program. But the offset is that we are expecting that by increasing the focus on chronic care management, that there will be reduced ED utilization and hospital admissions. So it's really sort of banking on the idea that moving upstream will have that impact downstream.
So I think important point to point out here is, so the CPC Plus programs and the predecessors really didn't generate any savings. CPC never did. CPC Plus looks more promising, but given concerns that hospitals had, this could ultimately be a loss to the TCOC. Chris, do you want to outline what sort of backstops there are on those dollars if the savings don't materialize?
I'm not sure there are any good ones at this point, and it's something that we, the state, should think about in terms of accountability for the practices.
It is. Hospitals are both enthusiastic and concerned about the significant engagement. In other states, the program was a leading edge program. Here, we're trying to get as many practices in as possible, which means everyone is not necessarily ready to transform. But that actually may pay off in the end, but we just don't know, because those that are sort of not as advanced, the potential for savings might be greater in the long run, but bitter pills will be.
So let me just put a slightly finer point on the financial numbers. Our requirement with the feds is to hit an annual savings run rate on a total cost of care basis by 2023 of $300 million. So the good news is that we're already at $273 million. However, as you see there, 2019 is going to bring in $60 million in care management fees. And that is likely to double and maybe even triple over the next few years. And so if that investment does not pay off, well, to say it the way the hospitals say, HSCRC has only one lever, and that's over hospitals. So that's their concern.
And the period by which they think it should pay off is like 3 years?
Depends on who you ask, but I'm with you.
It seems very short, given that here you're dealing with chronic conditions that would worsen over a very long period of time. And what you may find in the short term is that there are more interventions that cost you more money, and you find that people are getting better care. It's not like all bad, and the savings tend to be way down the road and harder to predict. But they're real, but they're just farther off.
But there's a piece of the conditions that should be very time sensitive. Should be very sensitive in the short time frame to intervention.
Right. And it's hard. I sat there with internal looking at different programs in this vein. It can be hard to tease out exactly what's going on and where the savings are. If it's wrong, you can conclude you're not getting any savings at all in a different way. Looks like.
I think the other thing, and kind of related to Ben's point, is that the research indicates that if there's only upside, then a lot of times you just end up spending more money. This, to some extent, really looks like it's upside only at this point, but the feds have moved their model that's like this with a track-free that has more downside risk, and is something that we in the state should be considering as we evolve our own version of what the feds are doing with respect to the Maryland Primary Care Program.
So the only thing we want to just point out is that as part of the population health strategy that's associated with the total cost of care model, we do have the ability to receive credits. So as we improve health outcomes for Medicare enrollees, we can actually receive credits from the federal government against the MD PCP costs. And what we do is we use databases, CDC databases, Berthus, to be able to identify, what are the conditions in the state that are really critical for us to think about from an improvement standpoint, and then we're able to put together a control to be able to monitor our progress against that control. And then the last sort of section relative, again, to the total cost of care contract is, again, sort of this idea of emphasis on population health. CMS has been really emphatic about saying, while we understand this model is underscores the importance of addressing Medicare enrollee health, we really want the state to focus on population health goals. And so we have what we called BIGS, Bold Improvement Goals, and really are working with the Maryland Department of Health, and in particular the Office of Public Health, to develop a statewide strategy on population health improvement. So really thinking about what are the conditions that exist in our state that really are impacting a great number of folks, citizens in our state, as well as thinking about from a cost perspective what's most impactful, and really then bringing together resources from across the state, public-private partnerships, to focus very specifically on those. And so the first big that's been identified is around diabetes. And so there's an action team that's been put together that's diligently working across multiple agencies and with some private partners to start to lay the groundwork for plans around a statewide model for diabetes. So you'll start to hear more about that in September when the draft plan is released. It'll be open for stakeholder input, but that's an example of, again, sort of the push from CMS to think beyond just beyond Medicare. So, yeah.
Just a technical point. Much of my outside research is in diabetes and obesity, and just if you're using Berphus for diabetes, it's and we heard this great presentation from the CRIS people. If you have a better, and even the Medicare claims. I did a 5-year kind of time series of, and they were a type 1 in year 1, they were a type 2 in year 2, they were cured in year 3. Even just if you don't narrow it down to kind of your endocrinologist or wherever they're, the podiatrist sees a chubby 55-year-old come in and says type 2, whether they're really just a chubby type 1 that's had it for 30 years. So it's a lot of money, and a lot of money that could be saved. So it's a very tempting area to go into, but the data is really poor. So if you've got another data source, or at least a little sensitivity to see what are we getting here, who really are, and it's who the population really is. Then you can get thinking about type 1s versus type 2s and exactly who's covering them and those sorts of questions. But I was just shocked by how even this, kind of heavy lift on multi-year claims, how just poor the data was.
Yeah, and our team.
So does that mean you're volunteering to one of that? I think that we have advocated, and we've particularly been insistent that Berphus is a bad source. It's a bad source, but keep in mind that for the population health measure, we can't just rely on Medicare because we're talking about population.
Yeah, I've seen even Medicare's poor.
Yeah.
Right. That's why I was thinking, Chris, if you had something that actually was coming off a medical record where you could then sort and say, is this person's primary care physician? Or is this a specialist in the area? The fact that the podiatrist and the ophthalmologist say type 2, no, you really have.
Yeah, and actually, I don't think the CRIS folks are here any longer, but they are part of the action team. So let me just explain sort of how the action team is set up. So there's a group right now, work group that's focused on building an inventory. So looking across the state at what are all the existing diabetes related activities, plans, programs underway. There is a data group specifically looking at what are the best data sources. The CRIS team is actually part of that data group that's actually headed by one of the epidemiologists from the HSCRC. And part of what CRIS is really looking at is how they can use lab data to better assess the actual A1C results of patients. And so we think that's pretty cool and innovative. And so they're actually bringing that kind of expertise to the table for the group to explore. And then the third group is sort of the plan group that will actually put together the actual document. Some of you may remember, probably I guess about 15 or 20 years ago, the cancer plan, the statewide cancer plan. So it'll be sort of similar to that plan, and it'll be really this way to sort of leverage, again, resources from the public space, from the private space to work together on this, and really asking people to get engaged starting in September. So,
And I
So
would
let
be
me-
happy to, Ben.
And let me put
not
back
one.
to your technical question. So Tequila's right, we have a lot of resources and data in Maryland that we can use, but for purposes narrowly of the outcomes-based credit, is that's comparing Maryland to other states.
Yeah.
Therefore, that means we have to use some other data source that's outside of Maryland, which leads us to BRFIS, which is the worst option except for all the others for this, as I understand it.
Well, BRFIS is going to give you outside, the more than Medicare sort of a thing. I think there is an intent, you could do more of a methodology than most have done in the past, this sort of thinking about which of the different claims we're willing to take is more authoritative than the others.
And we can share with you the methodology paper, which OAC just signed off on, so it looked okay to them. They're just actuaries.
I have higher standards than that.
Okay.
all right. So last slide. So just again, sort of to recap what Chris started with at the beginning, the HSCRC and MHCC have been collaborating on a number of different areas. Really strong partnerships. Great that we're co-located because it allows us just to walk down the hall to work together. But to start off with, APCD monitoring enhancements. Okay, so well, I know it's late in the day. A lot of stuff here. We're working together. We enjoy working together. we have common goals and really a great deal of opportunity as we move forward. So we look forward to continuing to talk with you guys and share information as it unfolds.
Thank you very much. It's a very
Thank you.
very fruitful and helpful discussion.
So one question that I think some commissioners before wanted to have asked, some that are no longer here, is where did those GBRs come from? And to the point that Chris made, that really it's the rate of growth that we share more about. And I think that it's a very simple answer, but can you explain that, Chris?
So how the savings come about?
How did we develop the global budgets for each respective hospital?
So it's based on their revenue as of 2013, and then the commission votes on a statewide increase every year. To your point, I think where you're going is that includes a haircut, if you will, for potentially avoidable utilization on things like readmissions and complications. And so that amounts to, I think, $60 million for this year on an all-payer basis. And then again, to the extent that
I'll leave it there, the adjustments up and down around QBR.
all right, yeah, sure, and there are other adjustments.
They go in both directions.
Go in both directions, but that PAU cut is just off the top. And then again, we have kind of, as we build what the annual rate update is going to be, then once you get to the bottom of that calculation, there are still a couple other tests to say, okay, is that going to be more than the Medicare total cost of care growth? If yes, then tamp it down some. So
and what are the goals?
Multiple opportunities for conservatism that are built into that annual rate update.
And is there an underlying kind of metric there, like GDP +1, something of what is affordable to the state?
Yep. So we do the price inflation based on global insights. Then we look at the data based on the demographics. So in the state, what's happening with respect to the aging of the population, where folks are moving. So that also affects hospitals' global budgets. So it's a lot of data that goes into it. It's very formulaic.
Okay. Yeah, but the plan as of 2014 initially was that it would be a 3.58%.
That's the cap.
It was the cap, and that was the average state GDP over the prior 5-year period.
Right. And that's like an 1115 waiver kind of cap, so that it's like cumulative, so it almost doesn't even count anymore. But we still look at it on kind of a year-to-year basis.
Will you sort of rebase at some
We're
point?
doing that kind of internally, keeping an eye on.
Yeah, you know, this 2013 will get less and less germane.
Right.
And you're sort of tying it back to the CON discussions. A lot of times we do see the GBR is the expectation is that some of the cost saving opportunities in CON are really hard to crank out because the existing global budget for many systems does seem like the floor under which they want to operate. Even when we see efficiencies, it's sometimes hard to twist those out. At the same time, it's also true that some of the conversions.
So if I could take it even more strategically, the question really is, what should hospitals be looking like over the next 5 to 10 years under a global budget? So if they're getting volumes out and they've got empty beds, should they be keeping that money? And if so, what should they be doing with it? And I think that raises the population health questions and a lot of.
Although if you're successful at moving that, they will be less dominant players in just the whole system. I mean, to a certain degree, it's like, I mean, it reminds me a little bit of tobacco tax. You know, it's a great funder for the first 5 years, but if you actually, you know, reduce smoking, what are you doing? Right. So, I mean, we do have a hospital-driven state. It makes perfect sense what you've done, but if your success may mean that your tools are left effective because now hospital spending is such a small percentage of total spending in the state. 10 years from now, it may be harder to
it's
turn the
going
knobs
through the hospitals, but what they're doing is more than just doing stuff.
And I think the problem is that the only lever we have is the hospitals in the system today. And as hospitals become a smaller and smaller piece of the total cost of care, the ability to use that single lever to manage that entire expenditure of care will become less.
And that's honestly why the new program piece is where we actually can, have doctors sign up on something where they take some downside risk. So this is part of moving along that continuum.
Questions? Commissioner Jordan?
Okay. Right. Thank you very much. I appreciate your time and the discussion. So Ben, would you like to share the upcoming activities for the September's public meeting briefly?
No, do I dare? So more CONs to come. So we hope to bring a recommended decision forward on the Baltimore City Hospice. School-based telehealth report is due. We will have some early results on spending for the privately insured in the individual market based on 2018 data. We're pushing hard to deal with that. We also will have, as I mentioned, a couple APCD actions. I mentioned the Baltimore City litigation, possibly that, as well as another collaborative study that should be ripe for commissioner review, being conducted by Johns Hopkins researchers looking at gaps in support for patients who ultimately commit suicide. And we'll have some appointments to consider for our cardiac services advisory committee. There have been some resignations and departures, and we waited till September to bring them forward. So those are what's on the table today. We are planning not to meet in August, but stay tuned. I'll try to get you a clear decision on that as quickly as we can. I thank you very much for your indulgence today. It's been really a great discussion across the whole host of issues, which is the healthcare commission's role. Thank you.
I'll entertain a motion to adjourn.
So move.
Is there a second? Is there any discussion?
Let's talk about adjourning.
Without opposition. Thank you, everyone.